with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Gone are the days of blind treatment and nation. Medical laboratory is here to bridge the gap. We no longer guess medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Let us rejoice and be glad, all Ugandans, generation now and the next to come. Medical laboratory is here to manage disease outbreaks, surveillance and through research. Medical laboratory, wonderful profession, the core of medicine. Men and women of Uganda, serving in the medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Gone are the days of blind treatment and nation. Medical laboratory is here to bridge the gap. We no longer guess medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Let us rejoice and be glad, all Ugandans, generation now and the next to come. Medical laboratory is here to manage disease outbreak through surveillance and through research. Medical laboratory, wonderful profession, the core of medicine. Men and women of Uganda, serving in the medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Gone are the days of blind treatment and nation. Medical laboratory is here to bridge the gap. We no longer guess medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Let us rejoice and be glad, all Ugandans, generation now and the next to come. Medical laboratory is here to manage disease outbreak through surveillance and through research. Medical laboratory, wonderful profession, the core of medicine. God bless us, men and women of Uganda, serving in the medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Gone are the days of blind treatment and nation. Medical laboratory is here to greet the God. We no longer guess medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Let us rejoice and be glad, all Ugandans, generation now and the next to come. Let us through research. Medical laboratory, wonderful profession, the core of medicine. Men and women of Uganda, serving in the medical wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Gone are the days of blind treatment and nation. Medical laboratory is here to greet the God. We no longer guess medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Let us rejoice and be glad, all Ugandans, generation now and the next to come. Medical laboratory is here to manage disease outbreak through surveillance and through research. Medical laboratory, wonderful profession, the core of medicine. Men and women of Uganda, serving in the medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. The days of blind treatment and nation, medical laboratory is here to bridge the gap. We no longer guess medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Let us rejoice and be glad, all Ugandans, generation now and the next to come. Medical laboratory is here to manage disease outbreak through surveillance and through research. Medical laboratory, wonderful profession, the core of medicine. Men and women of Uganda, serving in the medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. On other days of blind treatment and nation, medical laboratory is here to bridge the gap. We no longer guess medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Let us rejoice and be glad, all Ugandans, generation now and the next to come. Medical laboratory is here to manage disease outbreak through surveillance and through research. Medical laboratory, wonderful profession, the core of medicine. Men and women of Uganda, serving in the medical laboratory. and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. On other days of blind treatment and nation, medical laboratory is here to greet the Lord. We no longer guess medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Let us rejoice and be glad, all Ugandans, generation now and the next to come. Medical laboratory is here to manage disease outbreak through surveillance and through research. Medical laboratory, wonderful profession, the core of medicine. Men and women of Uganda, serving in the medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. On other days of blind treatment and nation, medical laboratory is here to greet the Lord. We no longer guess medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Let us rejoice and be glad, all Ugandans, generation now and the next to come. Medical laboratory is here to manage disease outbreak through surveillance and through research. Medical laboratory, wonderful profession, the core of medicine. Men and women of Uganda, serving in the medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. On other days of blind treatment and nation, medical laboratory is here to greet the God. We no longer against medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Let us rejoice and be glad, all Uganda's generation, now and the next to come. Medical laboratory is here to manage disease outbreak through surveillance and through research. Medical laboratory, wonderful profession, the core of medicine. Men and women of Uganda, serving in the medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Gone are the days of blind treatment and nation. Medical laboratory is here to bridge the gap. We no longer guess medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Let us rejoice and be glad, all Uganda's generation, now and the next to come. Medical laboratory is here to manage disease outbreak through surveillance and through research. Medical laboratory, wonderful profession, the core of medicine. Men and women of Uganda, serving in the medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Gone are the days of blind treatment and nation. Medical laboratory is here to bridge the gap. We no longer guess medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Let us rejoice and be glad, all Uganda's generation, now and the next to come. Medical laboratory here to manage disease outbreak through surveillance and through research. Medical laboratory, wonderful profession, the home of medicine. God bless us, men and women of Uganda, serving in the medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the home of medicine. On other days of blind treatment and nation, medical laboratory is here to bridge the gap. We no longer guess medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the home of medicine. Let us rejoice and be glad, all Ugandans, generation now and the next to come. Medical laboratory is here to manage disease outbreak through surveillance and through research. Medical laboratory, wonderful profession, the home of medicine. Men and women of Uganda, serving in the medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the home of medicine. On other days of blind treatment and nation, medical laboratory is here to bridge the gap. We no longer guess medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the home of medicine. Let us rejoice and be glad, all Ugandans, generation now and the next to come. Medical laboratory is here to manage disease outbreak through surveillance and through research. Medical laboratory, wonderful profession, the home of medicine. medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. On other days of blind treatment and nation, medical laboratory is here to bridge the gap. We no longer guess medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Let us rejoice and be glad, all Ugandans, generation now and the next to come. Medical laboratory is here to manage disease outbreak through surveillance and through research. Medical laboratory, wonderful profession, the core of medicine. Us men and women of Uganda, serving in the medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. On other days of blind treatment and nation, medical laboratory is here to bridge the gap. We no longer guess medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Let us rejoice and be glad, all Ugandans, generation now and the next to come. Medical laboratory is here to manage disease outbreak through surveillance and through research. Medical laboratory, wonderful profession, the core of medicine. Men and women of Uganda, serving in the medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. On other days of blind treatment and nation, medical laboratory is here to bridge the gap. We no longer guess medical condition, medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Let us rejoice and be glad, all Ugandans, generation now and the next to come. Medical laboratory is here to manage disease outbreak through surveillance and through research. Medical laboratory, wonderful profession, the core of medicine.
Request the volunteer to lead us in an opening prayer.
Still sometimes I can say that I will have already composed. So the other point,
The volunteer from the audience
banner, pull up banner,
can lead us in an opening prayer,
sola
and we start.
wali.
Okay, we have a volunteer ready. It has not one.
Pull up banner down. It's okay.
Okay, may we pray. Lord Jesus Christ, we come before you this morning. We want to say thank you for the day that you have given us. We want to say thank you for everything that you have done, all the preparations that have been going on. And we want to say thank you for bringing everyone safely here. And may you please accompany everyone who is still to come so that they get here safely. And may you assist us as we learn through these processes so that out of everything we'll be able to help your children. So Lord God Almighty, may you bless each and everyone who is here as we come together to bring our minds together, all for the cause of helping your children. May you help us so that by the end of the program, you will give us directions, you give us the way to go on how best to work things out with your guidance, Lord. We know all things are possible. You make us come up with something that is good and something that is going to work out for the best of each and every nation that's here. And for those who will be listening, this program will be going on virtually. May they learn something as well, so that each and everyone who learns out of all the discussions that are going to happen here, they take something, they have a message to take home and to implement. So I want to say thank you for the great minds which are gathered here. You have given us, Lord, you have given us all those people from the different specialities to come and work together so that by the end of everything, we have a way to go. We have the solutions of all the problems that we are having, the health crisis issues, so that out of everything we say from that time, from the conference that we had in Uganda, from the third ATIC conference, we had something come out, and that what we learned we are going to implement, and we say from that time, from the lessons of that time, things have changed. We thank you, Lord, in Jesus' name, amen.
Amen.
Thank you so much. Thank you so much for that wonderful word of prayer. Once again, I would like to welcome you all delegates to the third Africa Test and Treat Initiative Conference, which is against cancer and other NCTs. So in today's theme, it says, united by humanity, placing people at the center of care. So the goal of this conference is to integrate each person's unique needs by enhancing early detection, diagnosis, and linkage to care for quality NCD prevention and control. So in-house, we have various delegates from different institutions. So allow me to recognize them in this order. We have delegates from the Uganda Heart Institute, that is Dr. Elias Serata. Please wave to us. Dr. Elias, you're most welcome. We have our delegates from Makerere University Learning Institute, that is Dr. John Nakachwa. Dr. John, happy to see you. So we have our delegates from the Uganda Heart Institute, so Uganda Cancer Institute, Dr. Mawanda, Dr. Veronica, we have Dr. Isiko, and others. Please wave to the audience. So, yeah, and also we have Dr. Nolem Ogisha. We recognize your presence. Then we also have a team from the Ministry of Health, that is the pathology program. We have Dr. Achola Caroline. We recognize your presence. We also have a team from Zimbabwe. They traveled all along from Zimbabwe, and we are partnering with them, as you're seeing here. That is our flag. Then we have the Zimbabwe team, which we are working closely to organize this conference. May you wave for us, our team from Zimbabwe. Yes, we recognize your presence. Then we also have our valuable exhibitors who are already locked in. We have Medicel, which is at the back. We have Cefaid. Who is Cefaid? Cefaid is here in the corner. Then we have Kemat. I think they are still on the way. We have Prodiac. They are there at the back in the corner. Then we also have our team from Molbio. We are also happy to see you. Then I also recognize the presence of our members who came from Fred Hutch. Yes, the entire table from Fred Hutch. We have universities, that is IU. Happy to see you. We have Makerere University. Happy to see you all from Makerere. We have Busitema University. Yes, happy to see you. Then we also have delegates from the Allied Health Professionals Council. That is J. Nachiyinji. Yes, we also recognize your presence. So, ladies and gentlemen, this is the first day. I would like to take you through day one. We are supposed to start with remarks from the Director of Public Health, but the program has changed a bit. We shall revise it and then come up with an updated schedule that we shall go with. But we are done with the arrival of guests and delegates. Most of you have arrived and registered. We had an opening prayer, which was led by our volunteer. Then we are supposed to be having remarks from the chairperson of the NOC. Then we are also supposed to have presentation on Uganda NCD's situation analysis and priorities, which is supposed to be presented by Dr. Akia Charles, Commissioner NCDs at the Ministry of Health. Then after that, we shall have a presentation on intersecting challenges of the test and treat initiatives against NCDs in Africa, which will be presented by Dr. Susan Navanda. Then we shall have remarks from the Director General of Services, that is Dr. Charles Molano. We shall have a keynote speech by the Honorable Minister of Health, that is Dr. Jane Achen. We shall have a keynote speech from our chief guest, that is the Right Honorable Speaker of Parliament, Anita Amor. Then we shall have an official launch of the National Wellness Laboratories, the laboratories which are ready in the country doing wellness, launch of the test and treat research agenda. Realize that we really need research in order to drive this agenda forward. We shall have a launch of the NCD consortium. We realize that we need a group of stakeholders to come together and then to address the burden of NCDs. So we shall have a launch of the NCD consortium, and this will be presided over by our chief guest. Then we shall have a visitation of the stalls. We expect our chief guest to be here and her team, where we shall be moving one by one to visit the stalls. Then we shall have a coffee break. Then we have a session on leadership and governance. Leadership and governance, that will be starting immediately at 11, and this will be led by Dr. Isiko. Dr. Isiko is in the house, who will be moderating this session. So we shall have different presentations, one from medicine, presentation from the Secretariat, that is test and treat. They will present to us the achievements. The test and treat initiative started, this is the third time, so they will present to us the achievements when it started, when they had the second conference, what were the achievements, and what has been the progress over that time. So we shall have a presentation from the Parliament that will be led by Dr. Dan Kamara, who is the chair of the NCD Forum. We expect a presentation from Dr. Jackson Oren, who will be presenting about the current trends of cancer elimination initiatives in Uganda. We expect a presentation from the Heart Institute, where they will present on the current trends of cardiovascular diseases elimination initiatives in Uganda. Then we shall also expect a presentation from the civil society, where they will look at the rationale of policy addressing these NCDs. Then we shall have a panel discussion. Then after that, we shall have lunch break. After lunch, then we shall move into other discussions that will be looking at policy among other discussions. So basically, that is an overview. Then we expect to have academic sessions. These academic sessions will be looking at various topics, looking at topics to include how we could integrate NCDs in HIV, TB, chronic care, topics to include the use of machine learning in early detection of these NCDs, topics to include the role of forensic pathology in addressing gender-based violence, Then we shall also have topics from the civil society. Then we shall have an abstract presentation after that. Then we shall have topics. We shall have other topics and then followed by abstract presentations. Then we expect to have presentations from the exhibitors, Crowd Health, BioHealth Africa, and then finally we shall have closure of day 1. So ladies and gentlemen, that is a summary of what will transpire in our day 1 of this event. So at this moment of time, allow me welcome the chair of the secretariat, to also welcome us officially, so that we go to the next item on the agenda. Let us clap for him.
Thank you very much. Ladies and gentlemen, you're most welcome to this very important conference, the 3rd Africa Taste and Treat Initiative Conference Against Cancer and Other Non-Communicable Diseases. On behalf of the Secretariat, we are very honored to have you convened here. You are a special team which has been able to be convened so that we can initiate the launch of the National Implementation Plan for the Test and Treat initiatives in Uganda at Ministry of Health. So in a special way, I want to congratulate all of you. Non-communicable diseases are a big challenge to the entire world. So your dedication and your commitment to come and we put together our heads and we be able to drive and launch the resilient sustainable ways of quality improvement in our areas, starting with our practitioners. In our practice, it is very critical, and we are the ones who can be able to make it the best and will be able to eliminate non-communicable diseases. So all protocol observed, we want to appreciate all the institution leads. We are happy to inform you, we want to thank the Uganda Heart Institute, which is the co-host for the cardiovascular diseases in this conference. And we thank the Lung Institute, which is co-hosting all the pulmonary and the lung sessions, and we are really very humbled. We want to appreciate Uganda Cancer Institute. The dedication is really very important. So I want to update you that our guest of honor has gotten an emergency, and we are going to have our opening ceremony at 1. That is when she's coming in, together with the entire team. Our DG, our minister, the team is coming in at 1. But at this moment of time, we are taking up our agenda. On the agenda, we are having our panel discussions. which are going to take up the first role. We are going to begin from that session of the panel discussions, which is entirely ours, so that we can discuss our issues before they are being concluded by the guest of honor. So we are going to begin with our academia and practitioners panel immediately after break. Because already when you see, it's already our time for break. We'll pick up with that panel, and all of you, the practitioners and specialists in the house, in your respective capacities, we are happy that your contributions. We are eager to learn from you, and together we'll be able to improve. And after that panel, we will proceed to the CSOs, the NGOs, the manufacturers and suppliers panel. And that panel is, this time we are going to be happy that all of us are going to interact with that panel live. So that we are even as the practitioners and academia, usually the issues in advocacy affect us. So that panel will come in, and then, but that we will be able to, that panel will run concurrently with the regional panel, which is going to be online. I think the second panel, academia, all of us meet, and the practitioners, but the second panel we'll have it in sessions. So we'll have it concurrently running, so that the Zimbabwe team is going to lead the online team in that panel, as we are having the national CSO NGO panel. So those two will have to split, and we'll be able to get out. I understand we need a lot of time, and our time is much fast spent, but kindly bear with us so that we are able to achieve all the objectives of this conference. So I want to appreciate you, all of you, once again for coming. And right now, I want to welcome you for the breakfast, so that we use only 20 minutes to take it. And with the chairperson for the next session of the panels will take up, and all the specialists and practitioners from the different sections, you get ready, because you're going to come, and because we have to drive, and we want to, before the speaker launches the NCD research agenda and the National Wellness Laboratories, your contributions from the discussions from the panel are very critical. So thank you very much, and have a beautiful break time. I'm assuming the prayer we had from our sister from Zimbabwe is already also qualifying us for a cup of tea. Thank you very much. Members, let's move for the break tea. We use only 20 minutes. The break tea is just behind us. Let us pick a cup of tea, and we'll be able to start the session. Thank you very much.
God bless us, men and women of Uganda, serving in the medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory wonderful profession, the core of medicine. Gone are the days of blind treatment and nation. Medical laboratory is here to breed the love. We no longer guess medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Let us rejoice and be glad, all Ugandans, generation now and the next to come. Medical laboratory is here to manage disease outbreak through surveillance and through research. Medical laboratory, wonderful profession, the core of medicine. Men and women of Uganda, serving in the medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Gone are the days of blind treatment and nation. Medical laboratory is here to breed the love. We no longer guess medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession.
As we talk about Thermo Fisher Scientific ultra-low temperature freezers, what's critical to understand is that no matter whether you purchase the standard performance unit or the top-of-the-line TSX units, you're never compromising on sample security. All units are designed for protection of samples. That is our number one goal in the design of these units. When we look at standard performance, they're powered by H drive. So this refrigeration system is designed for quick recovery after door openings, good uniformity, low energy, low noise. As we move up to our TSX unit, this uses V-Drive. V-Drive incorporates additional benefits from the standpoint of greater uniformity, even lower energy usage, and some additional features that are built into the unit. Fisher Scientific ultra-low temperature freezers, what's critical to understand is that no matter whether you purchase the standard performance unit or the top-of-the-line TSX units, you're never compromising on sample security. All units are designed for protection of samples. That is our number one goal. As we talk about Thermo Fisher Scientific, when we look at our RDE, what's critical to understand is that no matter whether you purchase the standard performance unit, these units are powered by TSX units, so this is never compromising on sample security. Quick recovery units are designed for protection of samples. That is our number one goal. As we talk about Thermo Fisher Scientific, when we look at our RDE, what's critical to understand is that no matter whether you purchase the standard performance unit, these units are powered by TSX units, even though this is never compromising on samples. Some additional features that all units are designed to protect samples. That is our number one goal. As we talk about Thermo Fisher Scientific, when we look at our RDE, what's critical to understand is that no matter whether you purchase the standard performance unit, these units are powered by TSX units, even though this is never compromising on samples. Some additional features that all units are designed to protect samples. That is our number one goal. As we talk about Thermo Fisher Scientific, when we look at our RDE, what's into the unit. Built into the unit. talk about Thermo Fisher Scientific ultra-low temperature freezers, what's critical to understand is that no matter whether you purchase the standard performance unit or the top-of-the-line TSX units, you're never compromising on sample security. All units are designed for protection of samples. That is our number one goal in the design of these units. When we look at our RDE or FDE or TDE series in the standard performance, these units are powered by H-Drive. So this refrigeration system is designed for quick recovery after door openings, good uniformity, low energy, low noise. As we move up to our TSX unit, this uses V-Drive. V-Drive incorporates additional benefits from the standpoint of greater uniformity, even lower energy usage, and some additional features that are built into the unit. As we talk about Thermo Fisher Scientific ultra-low temperature freezers, what's critical to understand is that no matter whether you purchase the standard performance unit or the top-of-the-line TSX units, you're never compromising on sample security. All units are designed for protection of samples. That is our number one goal in the design of these units. When we look at our RDE or FDE or TDE series in the standard performance, these units are powered by H-Drive. So this refrigeration system is designed for quick recovery after door openings, good uniformity, low energy, low noise. As we move up to our TSX unit, this uses V-Drive. V-Drive incorporates additional benefits from the standpoint of greater uniformity, even lower energy usage, and some additional features that are built into the unit. Thermo Fisher Scientific ultra-low temperature freezers, what's critical to understand is that no matter whether you purchase the standard performance unit or the top-of-the-line TSX units, you're never compromising on sample security. All units are designed for protection of samples. That is our #1 goal in the design of these units. When we look at our RDE or FDE or TDE series in the standard performance, these units are powered by H-Drive. So this refrigeration system is designed for quick recovery after door openings, good uniformity, low energy, low noise. As we move up to our TSX unit, this uses V-Drive. V-Drive incorporates additional benefits from the standpoint of greater uniformity, even lower energy usage, and some additional features that are built into the unit.
Rheumatic heart disease, there are programs that are ongoing in the screening children, so we find that it's estimated about 300,000 school-going children are affected by rheumatic heart disease. Whether it's congenital or acquired, they all require intervention, and these are possible. And we know that if you that intervention is not
As we talk about Thermo Fisher Scientific ultra-low temperature freezers, what's critical to understand is that no matter whether you purchase the standard performance unit or the top-of-the-line TSX units, you're never compromising on sample security. All units are designed for protection of samples. That is our #1 goal in the design of these units. When we look at our RDE or FDE or TDE series in the standard performance, these units are powered by H-Drive. So this refrigeration system is designed for quick recovery after door openings, good uniformity, low energy, low noise. As we move up to our TSX unit, this uses V-Drive. V-Drive incorporates additional benefits from the standpoint of greater uniformity, even lower energy usage, and some additional features that are built into the unit.
So, we obviously have training programs for the nurses, and the cardiologists. So in medicine we have what we call the medicine and surgery. So the surgery is where you have the cardiac surgery, and the medicine is where you have plain cardiology for the adults and the pediatricians. And anybody who has to be able to sleep has to be able to sleep by the anesthesia team. And after who are able to handle it after the early washing, then you need to have to care. Doctors say
As we talk about Thermo Fisher Scientific ultra-low temperature freezers, what's critical to understand is that no matter whether you purchase the standard performance unit or the top-of-the-line TSX units, you're never compromising on sample security. All units are designed for protection of samples. That is our number one goal in the design of these units. When we look at our RDE or FDE or TDE series in the standard performance, these units are powered by H-Drive. So this refrigeration system is designed for quick recovery after door openings, good uniformity, low energy, low noise. As we move up to our TSX unit, this uses V-Drive. V-Drive incorporates additional benefits from the standpoint of greater uniformity, even lower energy usage, and some additional features that are built into the unit.
More than 250 and 5 members have completed PhD programs in cardiovascular disease and 4 are ongoing. So we've been able to step out. Traditionally, in our training,
As we talk about Thermo Fisher Scientific ultra-low temperature freezers, what's critical to understand is that no matter whether you purchase the standard performance unit or the top-of-the-line TSX units, you're never compromising on sample security. All units are designed for protection of samples. That is our number one goal in the design of these units. When we look at our RDE or FDE or TDE series in the standard performance, these units are powered by H-Drive. So this refrigeration system is designed for quick recovery after door openings, good uniformity, low energy, low noise. As we move up to our TSX unit, this uses V-Drive. V-Drive incorporates additional benefits from the standpoint of greater uniformity, even lower energy usage, and some additional features that are built into the unit.
Problems, so they tend to miss them. So we have to go out there and educate them and help them with eye detection. From eye detection and diagnose, and they should be able to identify what they can manage and what they can't manage. And we look at that we also have validation. It's very much and I feel slightly school programs as well. The school programs take advantage
As we talk about Thermo Fisher Scientific ultra-low temperature freezers, what's critical to understand is that no matter whether you purchase the standard performance unit or the top-of-the-line TSX units, you're never compromising on sample security. All units are designed for protection of samples. That is our number one goal in the design of these units. When we look at our RDE or FDE or TDE series in the standard performance, these units are powered by H-Drive. So this refrigeration system is designed for quick recovery after door openings, good uniformity, low energy, low noise. As we move up to our TSX unit, this uses V-Drive. V-Drive incorporates additional benefits from the standpoint of greater uniformity, even lower energy usage, and some additional features that are built into the unit.
Especially so for those which are so complicated for us to handle. So lastly, heart attacks are very common. I think I mentioned something called the characterization laboratory, which is a special room with a high-end gadget. At least I'll be happy to say that we have 3 other centers that have this machine. It's not a monopoly for the Heart Institute. You have Nakasero Hospital, you have Case Hospital, Chisui Hospital. But you know what it does? We are concentrated in Kampala. That means the access to care is still stuck in Kampala for those questions. So imagine you have a heart attack in Kotido. What is going to happen? How long will it take you to get to Kampala? So we have to come up with initiatives, we have to come up with ideas, we have to come up with innovation to try and increase and help access to care. At least for these, we know we can give you a drug, which is called a blockbuster.
Okay.
But again, if someone is going to get a drug of 1.5 million.
Hello everyone and welcome back to your video. In this video, I'm going to show you guys how to fix Zoom share screen error. So if you guys are having the same problem right now with the share screen option, just follow the steps that I'm going to show you. So the first thing that you need to do, guys, is go up to the right corner and click on your profile icon. Once you click on your profile icon, you're going to find a lot of options here. So here you're going to find the profile and the settings related to your profile, and from here you can change your status, and from here you can change your settings. So just click on settings, and once you are here in settings, you're gonna find yourself here in general tab. So here in the general, you can change a lot of settings depending on your preference. From here, you can choose
even professional bodies, medical professional bodies on your side, and other bodies that are in agriculture, social development, urban planning. I guess when we talk about urban planning, if you see the rate at which the greens disappear in Kampala, you wouldn't want to. So that's why we did urban planning again. So multi-sector approach is the way to go forward. People centered approach. Next. So what's next for us? To date, at this minute, construction is going on for a new home in Nakuru. But 45 million people and one Heart Institute is still a long way to go. But what we have in the basket, let's grab that, and then we shall ask for more. We probably need one on a regional basis. So what have we done to try and increase access? And there is for public health officials, I think you have a term coined medical desert. And a medical desert will mean you're in areas where certain aspects of health are not easily accessed. We know that even in Kampala, you may not be able to access certain specialists, even if they're in Kampala. So what has, on top of the construction being under the support of government, the plans are to create regional centers. And these regional centers are going to improve access to care, Not everybody who has a heart disease should be sent to Kampala. Send those who are complicated, send those who need more advanced care. Because of to and fro on our roads with the risk of accidents all coming. So, next please. Why do we need to have action? Time and in memorial, we always focus on government. But there's someone called the private players in the background. I think these should also be supported so that they can up their game. They may not necessarily put up high-end theater, but they can improve access to care for hypertension, diabetes, cancer, and lung diseases. So, confronting the epidemic and non-communicable diseases is still a challenge, especially in the third world. The approach is still to people rather than the disease. Even if you walk into a hospital and you complain, someone has a headache, has a back problem, has a difficulty in breathing, has a pain on the toe. So if you focus on the heart problem, you are going to ignore the rest of the individual. So even we don't focus on disease on that individual patient, but focus on the person as a whole. The key words: prevention, awareness, early detection, and diagnosis are very important. And after you've done all that, the care you're going to give, is it appropriate? Is it timely for starters? If it's timely, is it appropriate? Those are things that go through our minds. And so if it's, are the drugs available? Are the procedures available? All those questions come in. So I put that last because it's very important. Those who have patients, those who deal with patients, as we, and it's, social insurance is very important when it comes to that. On any other day, someone is being told, you need surgery, you need this procedure, you need this investigation done, but it all boils down to, can we afford? If we can't afford, that means you can't access that care. That means that care is virtually not Thanks for listening.
Yes, thank you so much, Dr. Elias, for your wonderful presentation.
I don't know what the next step is, but I think.
Okay, thank you so much, Dr. Elias, for the wonderful presentation. For the next step, we shall request you to take the front seat. So in the interest of time, allow me to welcome Dr. Nakato Veronica. Dr. Veronica, you're most welcome. So she's going to take us through the next session, that is the panel discussion.
Thank you very much, Dr. Elias, for this insightful presentation. Kindly, you can start the podium. Let me take this corner. So, different from the common panel discussions that we know, allow me to twist it a little bit to allow our experts how do you call that? It's more of a focused. We need these action points, a few guiding items that we can focus on as we look at implementing the NCT research. And as we look at collaboration with the other specialties. So we have seen you tell us about the Uganda Heart Institute, where we've come from, where we are, and where we are going. You have told us about hypertension being the most commonest NCD, at least highlighted in various publications and a few surveys. And I hope the team agrees with that. We have had that a lot. And you highlighted quite a number of risk factors, although you did not go into the regional effect that we tend to hear a lot about. You have talked about a number of activities in the community engagements, and as well as how you're trying to integrate them in the existing health systems in the country, leveraging on the referral systems as well as the established health centers. Today, we need your guidance on how, because after this session, after this whole conference, the agenda is, we would like to establish wellness centers. We are asking ourselves, are there policies, specific policies that we need in place to support or to collaborate with the Uganda Heart Institute to ensure that our people in the communities have these services screened? At least they should be screened early. You talk of screen early prevention. So are there policies we can put in place, or the existing policies that we could actually reactivate? Thank you.
Thank you. Wellness centers are part and parcel of what we need to tackle. First point is, as I told you, yes, the Heart Institute is there, but you're missing some other bigger players. You don't, I don't know if anybody is here from a private hospital. We have. So now, you are missing another player in direct patient care. You can partner with the Heart Institute. You can partner with those in the private sector because they are moving on. And one of the slowly and steady, Suri Hospital is very, very active in advocating for good health and in particular heart health. It's in terms of policy, I'm afraid the policies, but definitely there is need to go add on the policies. And what the challenge you should know is that most of the people are doing these things like on a voluntary basis, but people have to invest. People have to invest in this. Yes, you'll hear wellness center in a hospital. Yes, we talk of wellness, but already these are things that will be big. Or the only big thing that is, we are telling you come in, we screen your blood pressure, we screen your labs, and you move on. So, the policies should help people who are going to set up this and know how they move. They know their limitations. I think they need people policies that guide people who want to promote health. Any other question? And what wellness centers is it's used across the board to mean many different things. Because actually, I don't tell you have to be specific on what you mean by what you want to do from your wellness center.
Yes, and that's where we need your child to guide. If I really wanted to do an intervention that is focused, especially to screen for the commonest, that is the hypertension, what is that? Is it an equipment? Is it a specific health care worker that I need to put in place as we establish in these centers? What is that unique ingredient that should not miss to cover at least the hypertension?
I think basically hypertension is a blood pressure machine. But what you want to do in that wellness center is what everybody wants to know. So if you pick the patient, what are you going to do with that patient with high blood pressure? Are you going to treat? Are you going to refer? What do you want to do? So you have regulators, you have NCD program, you have the Uganda Heart Institute, right? It's a team.
Okay, and it brings us to another comment that we really wanted to know is that when we talk blood pressure machine, every center tries to put that in place. And of course, we have the different cadres trained to manage it. But is there a clear link or a pathway that these the community healthcare workers can utilize to access your care at the Uganda Heart Institute? Is it a special landline that we have to call a customer team if they have this patient to link? Or in these regional centers, have you tried to create that system to link the patient to care?
So I think we have an idea we should be having a customer care line to help with that.
Okay. Thank you so much for that. The audience, do we have a question?
Thank you so much, Dr. Elias, for taking us through the journey as Uganda Heart Institute. I have two questions. One, I noticed among the regional referral hospitals that you mentioned, where you have done advanced cardiac care, there's Lira, Jing, and Mara. I'm wondering why those three? Is it the infrastructure? Is it funding? Or you actually go to all these regional referrals because these are just examples? Because I imagine the risk is, the need is national, and those are just the 15 that we have. And then the other question is similar to what has been asked. Hypertension is managed, cardiac care and hypertension can be managed in other lower facilities. I'm wondering if you have, how do we help the clinical team identify that this case can better be managed at the Heart Institute? Because we've seen them, they really seem to learn guidance on this we need to refer. For the ones that need surgery, yes, but sometimes also the ones that are requiring medical care, they have complex, other issues that will require specialist care. So do we have, if I may say, like a list of conditions or a landline like Dr. Veronica has asked, that they call to consult and then we initiate a referral? Thank you.
Thank you. In terms of the surgical piece, is that first of all, we do outreach programs to all regional referrals in the country. We do outreach programs. These were identified by virtue of the infrastructure and their locations. We can't be everywhere. So we have to make choices on which particular areas, which hospitals are ready to receive us. And you should be aware that most of the hospitals currently are undergoing upgrading to improve of their theaters as well as high dependency care. So the choice is determined by one, infrastructure, and the personnel on the ground. And as well as locality for most of these programs. And if you start there and then you keep on the rest, because they should be centered at least and scattered across the country, but accessible from the different corners of the country. Then hypertension is a simple disease that comes from everybody who walks out of the clinical school should be able to hypertension. Even the clinical officer should be able to. So the government has a hierarchy. Ideally, it shouldn't be in the deep corner of somewhere in Uganda, in the corner of Uganda, then you bring the heart institute. We have the levels of hospital. Ideally, there should be a physician in district hospital. There should be a physician in the regional referral hospital. Those are the first points of call. First go to the regional referral hospital. Well, that's why those places have hypertension clinics. And when you look at this hierarchy, even the drugs that are kept in these hospitals are also, because there are drugs that a certain level of kind won't prescribe. Even the clinical officer are able to treat. But one starts from the regional referral hospital, then to the center. Usually, ideally, there should be the guidelines on if the patient is at this point and can't manage, send it on. But we also try and preempt by doing these outreaches. It's costly for people to come across to the city center. Someone will come from Kabale and even jump in Barra Hospital, which has a cardiologist, and come to the center. So what should be in place are policies and guidelines. Thank you. Any other questions?
Yes. Good morning, everyone. I'm calling to get in Tekla. My question is more of a comment, emphasizing what Dr. Elias about cardiology. Science that is very important for this very meeting. So, we talked about early detection. We need early detection and prevention. And here you emphasize the fact that affordability. Can we afford? If we can afford, then we can access. So that signifies to me that there is a problem of funding. Is that right, Dr. Elias?
The problem is at an individual level.
It's an individual level. Okay, so, but since we don't have this cardiology work at different, you said regions, we have only one heart institute. Still it's fun. You agree? It's fun.
Yes.
Yeah, it's fun. So, that is already a problem. Now, we want to improve several things in cardiology and also NCD, okay, NCDs. But we lack funding. But also, there is another aspect that you may talk about that actually there is money coming in to fund these projects and then take them to the lower facilities and all that. So, that is another perspective. It is subjective. Can agree or not. Okay, so we need drugs, we need wellness centers, but still, we see that the improvement needs investment in a way. Okay, does everyone agree? Yeah, we need to invest in this improvement. So, in order to promote health, as we are here. So, one of the things I wanted to illustrate this, to demonstrate, look at us here today. Today we've had breakfast, a small cup of tea with 2 bananas, not even bogoya, with 2 bananas, a sumbusa and a mandas. How much is that, doctor? Around, you say, that is 1,500. Yeah? Personally, I pay 900. over 900 to attend this conference. Okay? So, and that 900 does not include accommodation and transport. Yeah? So I would expect the breakfast I'm going to have like today to be a bit better because I traveled all the way from Lara and I reached here last night. So I'm really hungry. Only to find that I'm eating bananas, not even Ogoya, not that. Small 2 bananas that have been plucked. I'm not being political, I'm just giving an illustration on Doctor's points, what you are saying. Okay? So the money is there. Okay, I'm not sure for this one, but I'm just illustrating. It's just an example. I paid 900, over 900. And I know there are others who have paid, maybe through your institutions and all that. So I would expect to have a better breakfast. Maybe English pancake, maybe some katobo, yeah, some Irish, you know, and some sausages. So this is exactly what is happening to healthcare in Uganda. It is a bit of, we have the money, but how are we using it? Today, the theme is about centering on people. Dr. Elias here is a cardiologist. He's very important in this country. But today he ate 2 bananas, a mandazi, and a sumbusa. But he's working so hard, like he has presented here. This would be an opportunity to appreciate such people, to provide the best hospitality, and make them feel at home. So here he's facing a sad scenario. It's not a happy end because maybe probably we cannot afford. Or that money is going somewhere else. Okay, that is an illustration. And then the other illustration is where he's standing and presenting. Are you seeing his feet? Are you seeing his face very well? Why isn't he standing up here? Yeah? Why isn't it? Please, let me finish. Please. Yeah, this will help us. Why isn't the podium here? Are you all seeing me? Yeah? And these lights were put there for a purpose. And then Dr. Elias would be up here presenting his work, and we are all seeing him, and he's being recognized as Dr. Elias, the cardiologist. Yeah? It is not just for show off, it is just a people-centeredness approach, as our theme is saying. So, just recommendation, I'm not forcing. Please put the podium up here. We focus on the people who are doing the work. Yeah? And then he can gladly move from the podium without going on the ladders, now struggling, and then he can sit here and wait for his questions. So that's the same thing that is happening to healthcare. We are not focusing on the people, as the theme says. We are probably focusing on what we are putting on, the courts, the what, the offices and the big cars we are driving, UG number plates, but the people who are doing this work, yeah, they are not being focused on. Thank you very much. Those are my comments. Thank you.
Thank you.
Thank you for those recommendations and comments. And in the interest of time, we need to allow Dr. Elias to go. But before you leave, Dr. Elias, I want to appreciate you for the multi-sectoral approach. If we have to achieve something impactful in the area of something impactful as a put people in at the forefront. And we want to remember your keywords on prevention, awareness, early detection, improve diagnosis, appropriate and timely quality care. Thank you very much.
Kiongozi mpadde wano kibadde kijja kukolera atusooka omaliriza oyo It's okay. It's okay. Ngenda playing.
Thank you so much, Dr. Veronica, for the wonderful moderation. And also thank you so much, Dr. Elias, for the wonderful presentation from the Uganda Art Institute. So, in the interest of time, allow me to welcome Dr. Noleb Obisha from the Uganda Cancer Institute. Ladies and gentlemen, let us join our hands.
We're going to project.
So, Dr. Noleb will introduce himself as we upload the presentation.
Thank you very much, MC. And Dr. Noleb Obisha, as he said, and I am presenting on behalf of the Director of the Uganda Cancer Institute, Dr. Jackson Orem. I'm very honored to stand here with you, and hopefully we will be able to appreciate the initiatives that we have as a country to eliminate cancer by the time I finish talking to us. So thank you very much. I think I already introduced myself. I work with Uganda Cancer Institute, and at the Uganda Cancer Institute, I work with the Community Cancer Services Department. So the topic that I'm presenting on is current trends of cancer elimination initiatives in Uganda and East Africa. I added East Africa because Uganda Cancer Institute is now a regional center of excellence for oncology in East Africa. And so when we are thinking about initiatives for the country, we also think about the region. So listen to my presentation with that context in your minds. and I will be saying, are we together? Because I am a teacher, and that is one mannerism I was taught, to make sure everyone is following. So next slide. I thought of first painting the picture of how many we are in Uganda. The latest population census gave us this figure, 45.9 million Ugandans. When you think about eliminating the disease, and this is very important to know, you eliminate a disease in a particular geographical area in terms of public health. So there are some countries where some diseases have been eliminated, but there are some countries where some diseases have not been eliminated. And there are some diseases that we will see later. But importantly for us to note here is that 50.5% of Ugandans are actually below 18 years of age. So we are a country of children. Because according to our population, I think after 18 years, then you can vote, you can participate in many civil, political responsibilities at the country. I think you can see you're some of the oldest Ugandans if you're here. Because I don't think there's anyone who's here who is below 20. Did you know? My brother doesn't know that you are in the upper, section of Ugandans. But that is important for us to note when we are thinking about eliminating the disease. We are young people. Are we together? And then, I also thought, sorry, I keep going to my computer. I also thought that it's important for us to know the cancer burden for Uganda. At this point, I deleted the slide for East Africa because, and I'm sorry for the pie charts that are not visible on the screen, but you don't have to see the figures there. The commonest cancer in males in Uganda is prostate cancer. I don't know, the slide does not look the way I want. Why are we showing this side? Can't it be in the slideshow? There is a wine glass that you tap and then this side goes off.
It's not mine. Who is showing mine? This one.
Yes, that's what I wanted. Now, unfortunately, we can't see this, but this is important for us as we go down. And I know I have only 10 minutes. So in males, I failed to get a pointer here. But in males, the commonest cancer is prostate cancer. Now, in females or women, the commonest cancer is cancer of the cervix. But I wanted to emphasize that if I had a pointer, I would show. But when you see cancers in females, cervical cancer actually accounts for up to 35%. Now, 35% is really a huge percentage when you're talking about the population. Meaning that if we dealt away with cancer of the cervix, over a third of beds that are occupied by cancer patients at Uganda Cancer Institute would be free. Over a third of the work burden on health workers would be taken away. Do you understand? Over a third of the resources we spend on cancer would be saved. Do you see the reason why we are saying every health worker should screen for cancer of the cervix? Yeah? Now, this is the biggest reason I was showing that slide to us. Now, just for you to know that in 2020, in 2022, we had 36,000 new cancer patients diagnosed in Uganda. And then we lost up to 25,000. That's a huge proportion of the patients are diagnosed. And the biggest reason here is, one, because our patients are coming late. But the other reason is that many of our patients do not access care at all. You understand? So if somebody has a cancer diagnosis, the percentage that access Uganda Cancer Institute is actually on average about less than 20%. Because we have private cancer hospitals, but those treat a very, very small proportion of cancer patients. Are we together? Remember, we are talking about initiatives to eliminate cancer, but I thought it's good to paint the picture of the burden. But I also thought it's important for us to note that at Uganda Cancer Institute, 10% of the patients we will receive are children, 0 to 14 years. Are we together? Now, I want to I thought it's also important for you. I think this I have already said. When I said the majority of the patients present late, one of the cancers I identified is breast cancer. The breast is outside the body. You know, everyone can touch their breast. You can even ask their friends to touch. A health worker can examine the breast. They don't need a machine. You can, palpate. And if we think there's a problem, we need a machine, isn't it? But even for breast cancer, up to 80% of our patients come with advanced breast cancer. Are we together? If I ask the ladies in this room, how many of you have done breast exam in the last 1 month? The percentage would be very embarrassing, even though the breast is here. If I am lying, shout that I am lying. You see? You haven't shouted. But what I'm trying to say is, I am painting the picture so that we can all see our roles. It's very easy to say government, but what about you? You haven't checked your breast. You think the minister is going to come to your bedroom? So I'm trying to paint a picture because I have observed that in this room, the majority of the participants are probably not clinicians whose job is to examine patients. Are we together? Now, I also think it's important for us to see the trends of cancer. So, this is the trend of cancer patients seen at Uganda Cancer Institute since 2015. You see, it's a slope like we are climbing a mountain. And while it's not a slope, a gentle one, it's actually coming like upwards. You wonder as if it's going to come backwards. So, the number of patients is on the increase every day. Now, these ones you may not see very well, but we're trying to paint the trend of the incidence of cancer. If you can see, most of those graphs are actually going up. Save for Kaposi sarcoma, which is somewhere. I don't know, how do we get a pointer here? Someone who knows everything. When I press here, it moves.
Is it there?
It's not helpful.
Is it there?
But it's on your computer. It's here now. So again, I'm trying to paint a picture that the cancers are on the what? On the increase, in a general sense. Sorry, before using my computer. Next slide. Allow me to come here. I am not. Now, I just wanted to paint a picture of the cancer risk factors. Do you mind me saying here? No, I think you don't mind. Now, these are the cancer risk factors. The picture is displaying what is driving the cancer risk. If you look here, we have high prevalence of oncogenic infections, HPV, HIV, Epstein-Barr virus, H. pylori, the one that causes septic cancers, malaria. Malaria is a risk factor for cancer. The risk factor for Burkitt's lymphoma. Because the virus that is highest risk factor for Burkitt's lymphoma thrives in individuals who have had many episodes of malaria. Do you understand? So, if we don't control all those things, we can't eliminate cancer. We'll be just writing on water. And then we have, of course, rapid urbanization. You know, towns that you go to everywhere. People are eating Rolex, Commando, deep fried. All those are driving the cancerous factors. But as the urbanization increases, we have a lot of slums everywhere. Every small town you go to in Uganda, there is a slum. And this will be a drinking joint, grass thatched, but it's slum kind of. Now there are infections and risk factors that thrive in slum, including HPV. In a slum, people don't make responsible sexual choices, or in a bar. They don't. Out there. Okay? And then physical inactivity, of course. I don't know how many of you have jogged since Monday in this room. If I ask show of hands, we may be embarrassed. Somebody has shot up their hands. They don't want to be bandwagon with us. And then this table shows the prevalence of risk factors. But we won't go through that because I think the picture has been painted. Now we have initiatives to ease the burden of cancer on us as Ugandans. Those are really very important to highlight because later I will talk about what elimination means. Now, these are the initiatives we have to ease the burden of cancer. The UCI Act 2016, Uganda Cancer Institute is established by law. Not by policy, not by a directive, but by what? By law. Meaning, if Uganda Cancer Institute doesn't do what it should do, somebody can take the executive director to court. And if he's guilty, he can be imprisoned. You understand what it means to be established by law? So Uganda Cancer Institute is that powerful. That's the way Elias was telling us that Uganda Heart Institute is established by an act of parliament. So for me, I think this is an important step in moving towards easing the burden of cancer. Because countries where cancer is treated alongside other diseases, it's really difficult to treat cancer when you bundle with other diseases. And later I will show you why that is the case. But we also have a Tobacco Control Act. Nicotine increases the risk for over 20 cancers because nicotine in itself can initiate the cancer process. Altogether, I read a writing in one of the medicine textbooks that if you tie tobacco on the arm of people the way we wear watches, and you follow them up for 50 years, he suggests that 10% of those people could develop cancer there because nicotine is in contact with their skin. So he was trying to paint a picture that nicotine is that dangerous. Are we together? And our politician Kamara says that even snakes cannot come near tobacco because of nicotine. You understand? And how many people smoke? Don't put up your hand, But I can tell you there are many, even doctors, And then alcoholic drinks bill. So the alcoholic drinks control bill. The revision of the Equity Act started in 2023, and I think we haven't completed it. Really, the effort is trying to make sure that we regulate the consumption of alcohol, because we have an A in per capita consumption of alcohol. Per capita means per person, that each one of us drink a lot of alcohol, even if you're a pastor and you're broccoli. Some people are drinking for you, and that drives the risk for what? For cancer. And we have a parliamentary act, a parliamentary forum on NCDs. That is an important step in making sure that we fight cancer, because we have a forum by members of parliament to discuss non-communicable diseases. But we also have the Uganda Atomic Energy Council and Atomic Energy Bill. Atomic Energy Council is the one that regulates or guides on the use of radiotherapy or radioactive compounds. That is important in the fight against cancer. But we also have a Uganda National Cancer Control Plan, which is in the final stages of being approved so that we start using it. This is an important initiative or strategy. We have a National Physical Activity Day. I can ask you that date, and if you do not know, I will tell you to make sure you know before we leave. There are not many countries with the National Physical Activity Day. To just remind ourselves that physical activity is one strategy to reduce the risk for non-communicable diseases, but especially for cancer as well. We have a national nutritional guideline and also the Uganda's food nutrition policy. Now later on, when I am given the opportunity to talk to all of you, I will tell you how food actually drives the risk for cancer. So that when we are going to eat lunch, we choose what we are putting on our plates responsibly. Now we also have a cervical cancer control and prevention strategy. We are also in the move to eliminate cancer of the cervix. Later on, I will show you where we are. Then we have cancer treatment guidelines and cancer referral guidelines to help us how to treat cancer and how to refer suspected cancer. Now, talking about the establishing of the National Cancer Center, the UCI. Now, these slides are showing us the Uganda Cancer Institute has a vision, has a mission, which is a strategy for us as a country. That you have an institution that can plan, strategize, fight cancer. But I want to tell you that Uganda Cancer Institute now can do surgery. We can provide treatment for children. Basically, we are a fully fledged cancer hospital. Any treatment you can get in India, you can get at the Uganda Cancer Institute. Of course, not forgetting the congestion, the limitation in terms of human resource and resources, but at least we have a National Cancer Center that has all the treatment modalities for cancer. And thank God that our government has had interest in cancer and has invested significantly. Uganda Cancer Institute has a cancer reference laboratory. I want to tell you, Uganda Cancer Institute, maybe the only lab in this country that does cancer tests for free.
I'm in the conference.
This is another lab, that's it, where people don't pay money. Even for immunohistochemistry, where a single test costs like $150,000, we do them for free. For me, I think that's a good step in trying to address the cancer problem. Now, I know you had challenges with services at Uganda Cancer Institute, but at least let's give a credit where it's due. Yeah? The Uganda Cancer Institute has one of the state-of-the-art radiotherapy services on the continent. The linear accelerator we have is probably the next place where it is probably in South Africa. Are we together? These days I tell men that we treat early-stage prostate cancer without removing the prostate. And when this man is cured of prostate cancer, their sexual function recovers 85% to what it was before. Do you understand what I'm saying? You don't understand, because you haven't met men with prostate cancer who will say, go for surgery, and then they ask you, will I continue, doing my leg things? When you say, they say, well, what you am going? They disappear. But when you tell them, no, it will be fine, tomorrow they show up and say, start treatment tomorrow. So it's a good step that we have the linear accelerator that can effectively treat some cancers, but they have to be diagnosed early. Are we together? I have to keep reminding you of that because then it shows you your role. Now we have a community cancer services. Some of you have seen our yellow bus moving around. It doesn't go in every village, every LC1, but it's a step in the right direction. Am I right? Now, I also thought I should paint this picture that there is that building where Uganda Cancer Institute started from, and where it was here, there is this, very fancy, nice building. If you haven't been to UCI, you can come. And this building, we are going to name it now the Global Oncology Center. That is the boardroom information that only has. And the reason is, we want to create space where we can collaborate with centers globally that have something that we can learn from and benefit from. At the moment, it's labeled UCI Fred Hart Cancer Center, but that label is going to change. I hope the board does not change, but if it doesn't, I'm sure it will not. And then we have, of course, a 6-level ward building. You know there are challenges inside there, but it's there, And then we have, this building is about to be completed, which is going to house the East African Center of Excellence for Oncology, but it also has 350 beds for cancer patients, has labs. I think we have 6 theaters in that building. We have conference rooms, because we are a training center now for the East African region. Did I show you a picture that shows what we are training? So we are training cancer specialists in pediatric oncology, in gynec oncology, adult hemato-oncology, and we're trying to add other specialties. But the challenges we have? Recently we admitted 4 students to do radiation oncology, and 3 dropped out. Do you know why? We didn't have enough money to pay them, because we train specialists who are already working. Say what I talked about, that everyone is doing it like on a voluntary basis in Uganda Heart Institute. Because if those guys crossed and went to Rwanda, they earn more than we pay them. That is part of our role. These guys enrolled for 1 month and they quit. They said, now if I can't continue paying fees for my children, staying where I have been staying, what am I doing here for the next 3 years? And they left. You understand? And we have a small stipend for them. And it's not small, by the way, if I tell you the money. But we are not ready for faith, their daily income in order to come on. Are we together? But at least the training programs are there. If you guys mobilize money, actually people can enroll and they are trained. Are we together? Do you see why it's not easy to eliminate cancer? Okay. I talked about the community cancer services. I painted the picture of infrastructure. Now we have regional cancer centers. I want to tell you this is a nice one. When I met the World Health Council representative like 5 years ago, he did not agree with the concept of regional cancer centers. He said no. You cannot have cancer treatment in different places in a poor country. And his point is right. Cancer treatment is a multidisciplinary enterprise. You need surgeons, physicians, you need everybody. But in a country where people are so poor that crossing the Nile from Jinja is too expensive that they choose to die across the Nile, then you need to take services to them. And the beauty is that our government agrees. You understand? So we have a regional cancer center in Mbarara. You see the pediatric oncology clinic? That is at Mbarara Regional Referral Hospital. And this building you see here is our Northern Uganda Regional Cancer Center, just actually in the Guru municipality. Guru City Council, something like that. You understand? The hospital is now full. They have patients on the floor. If you haven't been there, when you go to Guru, just say I want to visit the cancer center, you'll see. So this is trying to make sure we ease the burden of cancer on us as Ugandans. But if you go to the Guru Regional Referral Hospital, the staff that we need, we don't even have 10%. You understand? So it takes time. When we invite them, train them, and we give them a stipend, they run away. So the money we are giving is little. And that money we are giving, I think, more than 80% of this, we don't earn that money. You understand our math? But it's too small for the people we need to empower to do the cancer treatment business. And I talked about the East African Center of Excellence for Oncology, which is a good opportunity because it means then we can attract resources from even the region. You know, there are some departments at Makerere University College of Health Sciences whose studentship, they are more outsiders than Ugandans. Did you know? Like at Makerere University, you find a department, 80% of students are non-Ugandans. Do you understand it? You know, when our friend was talking about where we put the money there, who stood on the, you know, up there. That's exactly what we are saying. Now you find a certain department, 6 Ugandan professors are teaching 15 non-Ugandans and only 5 Ugandans. Do you understand? So we need to really make sure the resource distribution is revived. This is a building that is going to host the East African Center of Excellence, and I try to put the services that are in that building. Now, this is where the building is now. So don't look at the artistic impression there. This is now the real thing. So if you haven't seen it, come and see. Now, these are the challenges that are really limiting our attention is the burden of cancer on ourselves. Low level of awareness. People come late, even for breast cancer. You know that people can have a breast lump for 5 years, and they only come when it's all ulcerated and smelling. Do you know that, or you don't know? Or do you believe me? Yeah, if you don't know, just believe me. If I show you the pictures of some of the patients that we take, you're like, this person was at home, and because there are a lot of misconceptions, beliefs. You understand what I mean? And I can tell you, that's not entirely for a health worker. Some of those are for journalists and civil society. Because otherwise, doctors sit in rooms and wait for patients. Of course, we have high patient volumes. If you come to Uganda Cancer Institute, this one, you will say, stop even talking about it because it's visible. But we have limited funding. Funding in patients' pockets, but also funding, even from the government. Even if the government chose to give us enough money, it doesn't have it. Staffing challenges, high costs of care for cancer, limited infrastructure. Those buildings I'm splashing up there, they are only in Kampala. And somebody from Kisoro cannot just come and spend the whole 6 months in Kampala. Of course, we have limited knowledge of the local cancer epidemiology. But we did a study recently, and I will show you a publication. Now, what do we mean when we say eliminating the disease? Because you see, in the program we have, it's the trend of cancer elimination initiatives in Uganda. And somebody read that and be like, what? I want to read those initiatives. Because when you eliminate the disease, it means the disease will no longer be endemic. Something endemic is something that is continuously present. So you make sure that disease is not present anymore in a particular geographical region. So if you eliminate cancer in Uganda, it means cancer does not exist anymore. But usually in that region, the disease will no longer naturally occur or saturating the region. And any cases will come from outside that population. Do you understand? When I studied in the US, if you came from certain countries, you reach the airport and they tell you to go and wash your shoes. Because you may bring worms from your country. Worm eggs in your shoes. Do you understand? Because they are saying these ones are not in the US, so don't bring them from Uganda. Do you understand? I don't know that makes sense. So we are saying we want to have initiatives to do that to cancer. Now, I'll explain to you what cancer is. I hope my slide came. Now, I give an example of eliminating disease. There is eliminating a disease, but it's also eliminating a disease as a public health problem. The two are different. You can eliminate the disease and it doesn't occur in that population anymore. But you can also eliminate the disease to the level of being a public health problem. You understand? I'll give you an example of a disease that is not a public health problem anymore. Cholera. imagine there's a time when cholera would kill many people. So maybe we are not worried about cholera anymore. You understand? Then a disease that is a public health problem, malaria. People are dying every day. We are even looking for a vaccine, and we started vaccinating. I hope that makes sense. So for schistosomiasis, some of you may not even know that this disease existed. The elimination criterion for schistosomiasis as a public health problem was defined as less than 1% prevalence of heavy intestinal infections. That is less than 50 Schistosoma pneumatobium eggs per 10 mils of urine. So now for schistosomiasis, we would look for schistosoma eggs in urine. You understand? And so every time we talk about eliminating a disease, we have to have a definition. Now let's see for cancer of the cervix. So for cancer of the cervix, to eliminate cancer of the cervix, this is the definition that WHO came up with. Eliminate cervical cancer as a public health problem. All countries must reach and maintain an incidence rate of below 4 per 100,000 women. You know how many ours are now? About 30. You understand it? The incidence rate of cervical cancer in Uganda is about 30 per 100,000 women. So we want to reduce that to below 4. Then we say we have eliminated it. Are we together? Now for cancer of the cervix, the reason why this was possible is because if vaccination of girls is 90% by the age of 15, 2 doses, and then screening of women is 70% by the age of 35, and again by the age of 45. At least a woman is screened twice. Are we together? And also, if women who have precancer are treated, up to 90% who have precancer are treated, and then also 90% of women with invasive cancer are managed, then if we do that continuously, we can eliminate cervical cancer in this century. Not in the next 10 years. You understand? So this is what we are aiming for. So each country should meet the 90, 70, 90 target by 2030. Now, if each country can meet those targets by 2030, then in the next 1 century, the world will achieve 4%, so 4 per 100,000 women incidence of cervical cancer. Does it make sense? I know you're not epidemiologists, but I hope it's making sense. Do you understand? Now, the cervical cancer for which we have these strategies: vaccination, screening, and treatment. Are we together? Now, for the other cancers, we can't vaccinate. Majority of the cancers in Uganda, we can't screen for any other cancer, by the way. It's only cervical cancer. Breast cancer, prostate cancer, we can't screen because we can't have the screening interventions accessible to every Ugandan. So if you can't do that, you can't claim your screening as a country. All you're doing is your opportunistic screening, where people who come will screen. But that is not screening for the population of the nation. Do you understand it? So you see how difficult it is for us to claim we can eliminate cancer. But we can only ease the burden on ourselves. I'm trying to comfort you. I have 2 minutes. I am glad the one who was timing was not watching me. Otherwise, I think I finished my minutes long ago. But if I don't tell you this, I will have cheated you. What is cancer? Listen carefully. Cancer is a disease that results from accumulation of DNA damage. You all know DNA? And Agatone in Uganda? I don't know in other languages. But every cell, whether a plant cell or an animal cell, has DNA. Now, DNA can get damaged. And in cancer, the damage can be from outside. You know, the sun's rays in albinos, nicotine in smokers, you know all these things. Are we together? Now, if there is accumulation damage and accumulated repair failure, the cell either dies or becomes a cancer cell. Now, the things that cause this damage are all over the place. And some of the damage can be inherited. You understand? Meaning that no one in this room can say, for me, I can't develop cancer. Of course, we pray that we don't develop cancer, all of us. Now, I want to come to eliminating cervical cancer in Uganda. The crude incidence rate at the beginning of 2023 was 30 per 100,000 women. Our aim is below 4. This is at the beginning of 2023. The mortality rate was 19.9 per 100,000 women. Women who die of cancer of the cervix. It's 119 by 100,000 women. And then, at the start of 2023, vaccine coverage for dose 1 was 75%. For dose second dose was 44%. I know the percentage higher, but I can tell you, you also know that the girls who are 15 years and below, that you know, who have not been vaccinated. Do you know any or you don't? I'm sure you know. So you can see we are still far away from eliminating what? So when shall we eliminate cervical cancer? Thank you very much. Now, the elimination of cervical cancer, there is a whole session on cervical cancer tomorrow afternoon. I hope you know the panel will be able to address this question. I hope somebody has done some mathematics to tell us when we shall eliminate, because that can energize us. Thank you very much. Over to you, MC.
Thank you so much, Dr. Lole. Thank you so much, Dr. Vero. Now we welcome Dr. Lole. Thank you. Dr. Vero,
nga nze nsigadde ne bangamba tebalina ennyonyi bali.
It's not a mistake, but you need to thank you, Dr. Vero. I'm happily associated with the Uganda Cancer Institute. And every time someone talks of the present, the future of the Uganda Cancer Institute, I'm really inspired. And I just watch myself and I say, oh God, I'm part of that transition. I'm contributing something positive to the community. So it's really quite inspiring. And I'm glad that you've taken us through the policies that are in place to support the Uganda Cancer Institute. You have highlighted the community engagement strategies that are in place and how you are expanding this to the communities. And as well, you have highlighted the diagnostic advances that Uganda Cancer Institute has been doing, including the high-tech machines. And at least I'm seeing some of our exhibitors on the back are very supportive UCI. And thank you for also honoring the invite to this. So the exhibitors are showing that they are continuing their support towards the NCD. Thank you for supporting those laboratory advancements. So Dr. Nore, your session will be a bit different. We know that you're quite empowered with a lot of knowledge about cancer. But allow me to invite a few people to ask you special questions in regards to your advances. So I'll start with Dr. Carol Achola. She is a pathologist, among the lady pathologists that inspire me, but she also sits at the Center of Learning for Pathology in the entire country and diagnostics. She has a question, or if not mistaken, an opinion or a recommendation in terms of diagnostic advances for the NCDs. Thank you, Dr. Miller, for your insightful presentation. I must say it was very detailed, and you have covered a lot of areas, from the community to diagnostics to care. But in line with our theme today, and I like to say Uganda Cancer Institute is a reference lab, and this is a public sector for cancer diagnostics. I'll start with a comment, then I'll give you the question after. I think it's very important, highlighted, we are moving towards personalized kind of care, cancer care, as well as also personalized really diagnostics in terms of wellness, of being able to identify those at risk. And I think the UCI has a lot of capacity in terms of equipment, in terms of the infrastructure generally, like you have shown us, and also in terms of the personnel. They are really highly trained, that brings on table something that we can leverage on as a country. Apart from fellowships, are there other ways that you would think we could collaborate in the health space to be able to optimize the investment that we see? Coming from the public side, CPHL side, we have a lot of infrastructure as well. There was massive investment that came on because of HIV. And over the years, we've tried to look at the opportunities that presented and demonstrated in some cases that we can actually leverage the investment there to do much more than we are doing. So I'm just wondering what other ways or what other framework we would, if you have a framework, we can play in other members, academia, other public hospitals, even you have an autonomous status. If you, maybe an example is we've had a lot of investment in genomics, really driven by pathogen surveillance given our region, but we've also demonstrated that we can use that same investment without having to bring on additional funding or additional expenditure in terms of infrastructure to do cancer genomics for facilities that are in need. For example, we are now doing genomics for marketing format to demonstrate make translocation, and our argument is that would greatly enhance. I know you're not so new to issues of pathology. Every time you need tissue, it's not adequate. You have a very sick child, you have to go back to the child's chest. So we are trying to validate a test that is able to use peripheral blood alongside the tissue-based methods to really reduce the invasiveness, but also be able to render diagnosis with less detriment to the patient. Thank you.
I answer one by one. No, thank you very much for that comment. Now you say we have the capacity, the training, but to be honest, the capacity that is available at Uganda Cancer Institute is probably like 1% of what the country needs. But you're right. It's available for us to build on. Now your question is, apart from fellowships, what other mechanisms do we have in place to leverage this capacity? Now I think I would spell out what we have, but also tell you what I think we can still build. One, we've been giving CMEs to colleagues at regional referral hospitals, not really equipping them with really practical skills per se, but just reminding them that be mindful that when a patient comes like this and like that, it's likely to be cancer. Because we found out that patients progress even when they are within the healthcare system. Patient comes to hospital with a breast tumor, they go home with it until when it's advanced. So we think we can actually have a lot of in-service training to improve the capacity of our colleagues at all different health facilities to initiate the cancer diagnosis process. Not to do cancer diagnosis at that level, but be able to suspect and refer appropriately. And some of the initiatives I shared actually are tools that are there. We have, for instance, a cancer referral guideline that clearly spells if you suspect cancer, where do you send this patient? But I'm sure even when we physically took those guidelines to districts, I'm sure they are locked somewhere in the cupboards. So that's an area where we can really collaborate with colleagues across the country to make sure that we improve the rate at which we suspect and refer.
Okay.
And this, I can tell you, the academia can come in, even single individuals. I think a few weeks ago, one of our fellows, Dr. Okecha, was at Kaolo Hospital, training health workers there how to collect tissue, how to process it, fix it, how to reduce the cold ischemia time. Now, if you're not a medical person, this may not make sense to you. But that's, there's a lot that some of us may know that our colleagues may not be practicing that we can actually pass on. That's one mechanism that I think is in place and we can expand and we can enrich to benefit us as a country. But there are also services that we provide for free, like immunohistochemistry, that I know many patients can't access because they can't afford. Dr. Sewataya kept saying, if you can't afford, then you can't access, even if it's next door. Now, those are there, but many patients, when they need immunohistochemistry, there are samples that need to be brought to cancer institute, cancer institute, but some samples are processed the wrong way, and you're the one who say you process it, that is not helpful. You can here 3 months ago. So those challenges of quality and gaps of within what we already have. Yeah, thank you very much. I hope I answered the question. Yes. And then you talked about the genetics, the capacity for genomics. I think it's true because gene experts are all over the place, and I think that's a platform where there are many other genomic studies that can be done that we are not making use of. If you find out how many gene expert machines are on Mlago Hill, they might be above 10. But you find this unit needs one, the other unit has one that is in the cupboard and is never touched for 6 months. But a patient is lacking a service next door, yet the machine is here. Now, in my opinion, that's kind of a leadership question. Because we have a lot of territorial behavior, like behave like dogs. This is my territory, no any other dog comes. But I think we need to put an end to that, especially in this era where some resource support has been, cut off. I hope we will wake up and realize that we have better share the resources we have. So I think that is another area where we can collaborate, but we'll go a long way in reminding ourselves that some of these resources don't belong to us as individuals, but they belong to the people we serve. By the way, for disease, today you are the provider, tomorrow you're the consumer. And I can tell you, that's a fact. Today you are here, feeling sweet. Patients coming and buying, tomorrow you're the one waiting for the doctor. Rather, whom you did train properly, because when we are doing this thing, there people are seeing us. Are we together? So if you're here and you're dodging work, just remember that tomorrow you're the one who will be dodged. When you go there looking for an officer and they are going for lunch, and their lunch never ends until 5, then you go home and you come next week. Thank you for that question. I hope I have responded appropriately. There are many hands behind.
Yes, Dr. Norem, I think your presentation has stimulated a number of people, and we have quite a number of requests. I don't know if you're still strong enough to stand there as you respond to them.
Yeah.
Because I'd like to offer you a chair up there.
Maybe my friend's request can be implemented now. I go up.
Yes.
So that I am at the center of my work.
Yes.
Thank you.
And to join you, if you take that seat, to join you would humbly request Dr. Judith Fajen to join you as an expert. She's a specialist in gynecology. And at least you told us that one of the commonest cancers among women was cervical cancer. So she's going to support you in that. And the next person I would like to invite is Dr. Salam Mujib. Kindly join Dr. Norem up here. Dr. Salam Mujib is a lecturer and researcher at the Department of Pathology at the IU. All of us have heard about that university, training quite a number of experts in our health sector. We are humbled to have you here, Dr. Salam. So he will support you as a researcher in academia. So we are going to also humbly request Dr. Isiko John. There is always an aspect of pharmacology that sometimes we think only comes in when we are managing the cancer. But as we think of strategies to detect early, to prevent the cancer, you talked about endogenous and exogenous factors that lead to cancer. So I think you'll actually give us support in that. You can pass this side. Yes, this side. And to join them, there is Dr. Nolan. Many people of late talk about lung cancer. I know it has not yet gained popularity, but it's something that has quite a number of initiatives that are going on in terms of research, in terms of prevention, detection, awareness, community engagement, and advances in diagnostics. So allow me to invite Dr. John Makachwa from the Makerere University Lung Institute to support Dr. Nole in this discussion, so that we don't forget that friend of ours that comes in a short time and makes our loved ones live in a short time. Thank you for accepting that invite. And of course, with the many hands we've had, somebody whispered to me and said, as we talk about test and treat, we talk about early detection, we talk about the future, how we prevent, eliminate the cancer. We cannot forget policy. But at the same time, we cannot forget an important ingredient, that is diagnostics. So we humbly request Dr. Carol Machola to accept. She is the assistant commissioner of the NHS, I know she likes to say more, but I want to say she holds a position that is close to someone I know that is going to join us today. These are the individuals that actually drive the diagnostics in the country at the Ministry of Health. Of course, they work with the team. So, as this team is seated here, before the audience comes in with a number of questions, Dr. Nole, yes, Dr. Nole, people will allow you to rest a bit and maybe take some water and have the lady seated next to you comment briefly about the cervical cancer program. I haven't seen her docket, but I know they have done quite a number of initiatives to support the early detection, the screening, the community engagements. But we would like to hear more from you. What one thing do you think that this entire group, the diverse team we have, that they could take home as an action point towards prevention of cervical cancer?
Thank you very much. My name is Judy Najani. I'm privileged to work as a gynecologist and obstetrician at Mamulago Specialized Women's and Neonatal Hospital. I've been a doctor for quite a long time. And I have a passion for cervical cancer because I have experienced it firsthand. I've lost relatives to cervical cancer. And I also have a relative who survived cervical cancer. She did, when we talk about surviving cancer, any cancer, we usually do something called a 5-year survival. So she's been living now for over 15 years, so she's beaten the 5-year survival 3 times. And yet she came in with quite a late stage of disease where we could not operate and we needed to go to other methods of cancer treatment, which is radiotherapy. I like to call that in layman's language, burning the cancer, and the chemotherapy, which is putting medicine that kills cancer cells in a drip. I call that in layman's language, drowning the cancer. And of course, the surgery is cutting the cancer out wherever it is. So those are the 3 treatments. Now, one thing that I just want to emphasize again from Dr. Nole Mugisha's presentation, you realize that while the general information about cervical cancer globally is that it's the 4th most common cancer among females, but yet for us in the low to middle income countries, it's actually the commonest cancer that affects females. It even comes before breast cancer. But the two go together side by side. Now, it's very easy to, it's very easy to think that cervical cancer is a disease of the low socio-economic class. But I will tell you, I have seen women even in the high economic class being affected by cervical cancer. In terms of early detection and prevention, anytime you have a diagnosis of any cancer, just know that it is a long and lonely journey to treatment. It starts with the suspicion, the suspicion, could I have a cancer? Could I have a cancer? And most of us want to say, no, I don't have a cancer, no, I don't. So even when people walk into health facilities, they come into the hands of health workers. Sometimes we, the health workers, miss the opportunity to make the diagnosis early. Much as we are skilled, we are highly knowledgeable, but a patient comes, and this is very common with cervical cancer. First of all, the first signs of what the patient will complain on, cervical cancer affects a part of the body that it's taboo to talk about. No one wants to come and say, after I had sex with my partner, I saw a little bit of blood, from my vagina, from the birth canal. Nobody wants to talk about these things. And so patients will come in and probably some Now, for you to have early detection for cervical cancer, you must look in. You must look up the birth canal and look at that cervix and see. That is what we do at screening. But how many health workers actually do that? It seems to be a preserve of those of us who deliver women, and that is like our area of work. I am always in that area of the women in the birth canal doing something, so it's easy for me. But yet we can actually teach every health worker to do a simple look in up the birth canal and look at this woman's cervix. To me, that is one thing that will really go very fast. So it doesn't matter whether this woman comes to me as a gynecologist up here, whom she may not see, because most of us again we are at the higher centers, we're in the urban areas, and it's a rural population that we need to really be screened. So if every health worker can do that, this is my personal opinion. The cervix is actually accessible. When we go to bathe as women, sometimes we do something called douching. If you're not a virgin, you can actually feel your cervix with a finger. And sometimes I feel that if women were actually taught to feel their cervix, just like we tell them to feel their breast, they may be able to feel that something is wrong with my cervix. It doesn't feel like the normal cervix that I usually feel when I go to bed. That's my personal opinion. That is not anything. That it comes from a life of working and seeing the effects of how miserable a family becomes when a woman is given a diagnosis of cervical cancer. It's late, you cannot operate, you must take her through all those other expensive and difficult modalities of treatment. I'm taking a lot of time, but I'm so passionate about it. Of course, the other thing is awareness. Awareness. That one we cannot go away from it. The public must be aware that cervical cancer is still a problem. We need to screen and we need to demystify the language. The health workers want to talk about these things. We use medical language that the public cannot understand. We need to make it simple. We need to help them to be able to understand. And I think we need to really begin to have critical conversations within our families. Let's make cervical cancer talk as easy as any of the other things we talk about in social media, whether it's politics, criticism, whether it's anything else, football, which teams are playing today, who won this match and that. That's where we need to get to. We need to talk about this, talk about it, and of course, not just talk, but move to do, find where do I go to screen, what do I expect, what can be done if I test positive. So just for now, that's a big comment.
Thank you very much, Dr. Judith, and I hope none of you feel protected. However, I don't know if the modern generation, they call it Gen Z, if the generation can be ready to do a self-examination of the cervix with the kind of the nails we always wear. So I'll leave that comment because I don't know if we are safe. Because after doing some trauma, they might come to know those units and knowledge says that patient to the gynecologist for biopsy. And as a pathologist, I don't find cancer when it was trauma. But thanks for that insight. I've not tried it out to feel for the cervix. So don't ask me how it is.
That is just my personal opinion, like I said. But now we know that we can do self-collection of samples. So that's another option. If people want to come to the providers, there is room for them to collect their own samples to have HPV tested.
Yes, quite a number of initiatives in place. And I know a big part of them where we are trying to really make sure screening reaches the lowest person in our communities. So I'm glad to be part of that. And I would like to try and switch to this table. This table seems to be a little bit, although it's balanced, it's balanced. The gentleman is in the middle, but the gentleman will allow the lady to speak again. So Dr. John, at the Land Institute,
we are supposed to come out from Africana.
I do not know if it is policy supporting you, or it is research supporting the initiatives, or is it the community cry that is pushing all these advances that we are seeing around the lung cancer? And this thing at the UCI, I've got a chance to work with them as a collaborator, because we do a little bit of diagnostic support, and we have seen patients being managed at the UCI. So I might say it's another cancer that you have tackled nicely. However, I would like to know, are there challenges or are there issues that you would want us to really focus on? If we were to take this down to the communities, because we want to place the people at the forefront of the prevention of lung cancer. Are there strategies? Are there policies that need to be created or be implemented? Collaborations to be improved so that we see lung cancer really also eliminated. I don't know if we can achieve the elimination.
Thank you so much. My name is Joanna Control, on Protocol Observe. I work with the Makerere University Lung Institute, and I happen to be one of the people working on the lung cancer project. So the lung cancer project happening at the Makerere Lung Institute has been running for about 4 years now, and it is a research project, so we are being supported by research. Yeah, so from our findings in the lung cancer project, we've noted that the cancer burden is actually high in our country. So this study is happening in Uganda and Tanzania. So we've noted that there is a really high burden of lung cancer in our population, and majority of our patients are females who are non-smokers, peasant farmers, and of course, like other cancers, they present late. Most of our patients are diagnosed with stage 3 and stage 4 lung cancer. I think there is a role to play because we find that some of our patients will report having treated clinically for TB. So there is also that time that is wasted. So we think the healthcare workers also need to know. Of course, it is quite hard because the presenting symptoms of lung cancer might not differ much from the other respiratory diseases like TB. So we find that a patient will present to the lower health facilities, even the national referral, and they are first initiated on anti-TBs. So I think there is need to create awareness on that. Then also, we need to create awareness in our communities. These patients will present with a cough for over 2 years, treating for allergies, infections without improvement, and they'll only present to the hospitals when they get maybe difficulty breathing. And this could be because the cancer spread and they have a pleural effusion, or because they coughed up blood. So we really need to create awareness. So we call for more collaborations. Ministry of Health, maybe if they can support this. But lung cancer is a really big burden in our countries. Thank you.
So Dr. Noel, as you're telling us smoking is among the modifiable risk factors, I think we need to increase the talk. As we are talking cancer, cervical cancer, breast cancer, we may need to look out for how to address the lung cancer issue as well. Much as for now it's still in research, and I'm sure it will not shaken us a lot with many numbers for it to be in our top 2. Of course, we'll expect to see whether it's affecting women or men. Although I can see, Dr. Noel, did you tell us what is affecting the children more? Well, another talk. Okay? Yes, I know. I hope the audience, are we following? Because in the next few minutes, we'll have to ask these people if there is something itching. I know someone has been itching there. You're going to get that chance. Kindly listen to them. We are having Dr. Salam Mujib. He has done quite a lot of research. When we talk of NCD, many of us forget that also there is an enemy that we thought was for only the elderly, and that is dementia. Dr. Salam has done something a lot about dementia, and he has told us that among the modifiable risk factors is as simple as anemia. Am I right, Doctor? Yes, kindly, Dr. You're passing that mic. Yes, he has told us it's anemia. But among the patients, at least from Dr. Lago's presentation, maybe forgot to tell us that one of the pushers or the movers to improving diagnostics was the problem of anemia among the cancer patients. So Dr. Salam, I know you've done this research probably in the normal population. Is there a chance that you can demonstrate this, at least among the cancer patients? Or should we think that their anemia, once sorted, they do not get the dementia? Because dementia is quite an issue. I've done research on it, and mine was more of autopsy, and I must say, yes, I found quite a number of individuals with these features. So is this a disease that we can prevent at an early age stage? Is it easy for us to do this at the community level in awareness? And I also saw you looking at biochemical markers. Is there that specific marker that you found out that we could actually target in our screening strategies to be able to prevent dementia in our population? Thank you.
Yes, thank you so much. I'm Dr. Salam Mujib. I'm in Uganda. I've been here for more than 10 years, so I think I'm qualified to call myself a Ugandan. But originally, I'm from Nigeria. I'm part of the team that was sent by the federal government of Nigeria to start the medical school at Islamic University in Uganda. It's popularly known as Abid Medical School. Before going to the question, let me quickly talk about dementia. Because whenever we hear dementia, what normally comes to mind is memory loss. Dementia is more than memory loss, and there are other disease conditions that might mimic dementia. So we should not mix it up. One thing I would like to first mention is delirium, which is common. Then we also have anxiety, we have depression, we have amnesia, we have mild cognitive impairment. All of this might be mistaken for dementia. So I don't think, or I don't know if the words I'm using are big grammars, because I'm assuming that most of the people here in the health profession. So I don't know a language I can use that will break it down further than that. But going back to dementia, there should be at least impairments in 2 or more cognitive areas, not just memory loss. That is one. We have issue with language use, and thinking, and ability to do daily activities. From our studies, mostly, we see that there are some risk factors, and being a female gender and above 70 years is one of the major risk factors. And we come to look at the female gender. We came out with some findings. First, we see that the female have better health-seeking behavior compared to the male. Quickly, when they are sick, they call their daughters who don't want them to die, they take them to the hospital. But if it's a male, they tell the man to man up. It will be doing like a man until when they see that they're going to die. So mostly men don't go to the hospital except when they see that this one might likely lead to their death. Then when they are telling their children that they are sick, most children will tell their father that they are pretending. And before the man will cry out also, it will have been very big. So as we are talking about cancer, that always people come to the hospital when it is late. So similarly, the case of dementia is not different. Then in the society or the area we find ourselves, we see dementia as also act of God. Some people think that people are being punished for one bad deed they have done before. So they don't want to assist anybody with dementia. They see we have stigmatization. So even the family don't want to bring out the patient suffering with dementia. So those are the areas we have to first understand. So we're coming to memory loss at age less than 50 years. That is when we study. Our study is for 45 years and above because there are many changes in lifestyle. We see that we used to think that dementia is old people's age. Normally they put 60 and above. But we are able to establish that people younger than 50 years can come down with dementia due to lifestyle changes. And one of the lifestyle changes is this alcohol consumption and use of nicotine, which has been talked much about. Then another thing we come to establish is the use of our social media. People are not using their brain again. We said one of the risk factors is thinking. Most of us are not able to think. If I give you a small mathematical calculation, the next thing is that most of us will go to our calculator to try to use it to find the solution with the mathematical calculation. So once we are not using our brain, the brain will be useless. So most people, when you go to social media, what they do is not anything challenging to the brain. So they just want easy way to answer, to get answers. So those are the background. So with our lifestyle changes, the kind of food we eat, the alcohol consumption and all that, if all of us live long enough, we are likely to come down with dementia. And we know the struggle we are making, know the effort we are making. We cannot imagine when we are 60 years old, we cannot remember where we keep our money, the bank we use, not to talk of the PIN number and all that. So it's a very big problem. All of us should be concerned, and that's why we take up interest in studying dementia. Now going to a question on anemia and biochemical biomarkers that we can use to detect dementia early. I should tell us that there are many forms of dementia, and there are some that are modifiable. If we detect them early, the kind of food we eat, we can use it to modify. Once we know the kind of food we eat, the earlier speaker talked about the food. There is this diet called Mediterranean diet. So it is common around the Mediterranean Sea. But any food we eat that has the component of that Mediterranean diet is also referred to as Mediterranean diet. In Uganda here, if you look at the food we eat, mostly is carbohydrates. We have rice, we have kosho, we have we put Irish potato, at times they put scallow, they put rice, they put yam, and all of them are carbohydrates. So that one is not a Mediterranean diet. Mediterranean diet is fairly low in carbohydrates, more of protein. Then we have legumes, we have beans, then we have nuts, either granules or peanuts is there. Then we have fish, much of fish. So any food we serve that is rich in all that is called a Mediterranean diet, and it has been started to be protective against coming down with dementia. So if you look at the food we eat in Uganda, I think we have to improve on that. So with the food now coming to anemia, when we have food rich in all those ones, we might not likely have anemia. Food rich in this fish, then there are some antioxidants like vitamin C, like vitamin E. So there are those supplements that's also there. So when we are talking of anemia and dementia, we look at old people. If they have problem of swallowing, and that's maybe 70 years and above, at times they forget to eat. Then even when they are eating, they have problem in swallowing, and when they are not having the necessary ingredients in their food, so they are most likely to come down with anemia. Now linking cancer with dementia. So we have seen that almost all the NCDs, they have the same risk factors. We are able to establish cardiovascular disease and dementia, that they have the same risk factors. As I'm going to present my papers tomorrow, we are going to see that whenever we are making diagnosis of cardiovascular disease, we should be thinking along that line of dementia. I'm going to present on some hematological biomarkers and also some biochemical biomarkers. The way we see the picture of cardiovascular disease and cancer, the same way we are going to show it to us in the present tomorrow. Is that whenever you are thinking of dementia, we think of cardiovascular disease, we think of other diseases, similarly, vice versa. So in a nutshell, to answer the question she has asked us, all our routine laboratory tests, we should give attention to the findings. Apart from the special tests that are used to diagnose cancer, even our normal CBC and urinalysis can help us to make diagnosis of these cancers we are mentioning, we are talking of. So I think I have to stop there. There are correlations between all these LCDs and dementia. Thank you so much.
Okay, there is lots of time. Dr. Isiko, just a comment in 1 minute. With your specialty in pharmacy, do you think we've given enough information to the communities about the risk of the herbal drugs, the other medicines that we think treat the chronic coughs, the medicines that we think treat the other diseases that could be exposing us to risk of NCDs? Do you think we've done that right as a country, or we need to do more?
Okay, thank you very much. My name is Dr. John Isiko. I'm a clinical oncology pharmacist based at Uganda Cancer Institute, Mbalaga Regional Cancer Center. Thank you for that question. In the interest of time, I will be very brief. But before I answer the question, I would like to talk about a few issues here in regard to pharmacotherapy, and particularly in the lineage of cancer treatment. As we intend to achieve the goal of early detection diagnosis, of course, the endpoint of all this will be the treatment. Because once we detect the cancer early, or whatever NCD is, the next intervention is to ensure that this patient receives treatment as early as possible in order to have better treatment outcomes. Particularly in regard to cancer, we have quite a number of interventions that include surgery, radiation, chemotherapy, targeted therapy, among others. But now, in order to have better treatment outcomes, it implies that we should achieve high levels of treatment adherence. And in our country, the most used modality is chemotherapy. Good enough, we have on board the immunotherapies and targeted therapies, despite the relatively high cost. So, given the treatment side effects, it can impact on treatment adherence. Thus, so it implies that we have to work as a team of multidisciplinary teams to ensure that the community is well sensitized about the rationale or the relevancy of adhering to treatment, because the good thing is that the medications are available. Secondly, the medications, if used inappropriately, can result into disease. So it's a problem. Access to medication should be handled with caution, because if you find that in the community, quite a number of people will do self-medication, and in an attempt to self-medicating, they end up having issues, other conditions now develop. So we have to work as a team to ensure that we pass on the information regarding the safe use of medications to the community, so that we don't have diseases that are arising from inappropriate use of medications. And then training. In order for us to be able to deliver this information well, of course we need the knowledge, adequate knowledge. So it means that we have to have training programs to ensure that the healthcare providers are well equipped with this knowledge, as well as people who are involved in community sensitization and outreaches. Then I also wanted to think about the research, because it is through research that we shall be able to find out the gap, and also how big the gap is in order to design appropriate interventions to address the issue. Lastly, I want to talk about innovations in the pharmacist perspective. So, as we think much about the limitation in funding, because I understand Uganda, it's a country that's still limited financially, and we have limitations when it comes to budgeting. So if we have funding as a problem, what can we do within the little that we have. So, as pharmacists, there we can use pharmacological principles, such as dose rounding of chemotherapy, which is one of the projects that I'm working on, which can aid us to use less than what would be required to manage a condition without compromising treatment outcomes. So, in short, as a team, pharmacists can't work alone, so we have to work hand in hand with other professionals, doctors, the lab scientists, our leaders in government, so that we can work towards a common goal. Otherwise, thank you very much.
So thank you very much, discussants, and I know many of you are asking why I brought Dr. Carol back up there. Like I told you, the Ministry of Health, through the National Health Laboratories, has done a lot of initiatives to advance diagnostics in the country. Would like you to, or before that, I know that your team has also supported the entire country in confirming diagnosis of hematological malignancies, the famous leukemias, with one of the most advanced technologies we have in the country. So one of the things I would like you to assure us or comment on, all these initiatives, all these services that we have tried to place at the regional centers, the district hospitals, are they quite accessible in the community for the screening and early detection? Or we have to worry about the affordability? Thank you.
Thank you so much, Veronica. All protocols up. My name is Dr. Caroline Machola. I work in the Department of Lab and Diagnostics. The Department of Lab and Diagnostics takes care of laboratory diagnostics, clinical pathology, and radiology and imaging services across the network of the Ministry of Health facilities. When you look at the laboratory services as we know them, we start from Health Center 3, increasing in complexity, up to the national reference laboratories that we have, like the Central Public Lab and other collaborating advanced labs. And then for imaging, we have imaging services starting from Health Center 4. And the imaging services in particular, we have ultrasound scans and x-rays. And from the discussions we had in the morning, we know that these are very critical for cancer diagnosis. No single test is able to diagnose cancers. We should be able to look at the clinical examination findings alongside lab and alongside the radiology and imaging that may be indicated. So yes, we have the facilities and we have the infrastructure and the service provision going on. I want to give an example of cancer screening for cervical cancer. If we look at our postnatal care package, cervical cancer screening is part and parcel of it. What may differ is the modality. As a country, we are still using all 3 different modalities depending on the availability of the resource and that particular facility's infrastructure and personnel. So we're able to do HPV testing. We're also able to do the visual inspections that are run by the midwives and overseen by the medical officers and the doctors in the facilities. And we're also able to do pap smear through the referrals of diagnostic services to improve care. So yes, as a country, I think we have the infrastructure, we have service provision. What we may need in a few different institutions and scenarios are we need to strengthen our teams to be able to have a multidisciplinary approach and to be able to communicate. Over the years, our challenge has been we are screening, but actually how many are we able to treat? So those are areas we need to strengthen to be able to have data that we can interpret and that can inform us about the interventions that we are putting in place. In line with today's theme, we are talking precision diagnostics, we are talking personalized care, looking at the individual patient's needs. Again, yes, for cancer care we start basic and then we advance as we narrow down on the cancer. Again, allow me to add on what Dr. Noleb shared in terms of infrastructure availability and the capacities we have in our higher level facilities to be able to provide precise and accurate diagnosis for cancer care. We're also now leveraging on the advancements that we have. There are already trials in other places looking at using AI to support screening of the cervical cancer screening for cancer. So those are things that as a country we are keeping an eye on and would be able to adopt to increase access to make sure that more of our women are screened. But also, like earlier alluded, at our higher level facilities, we're actually able to provide all tests that we require for targeted therapy in the context of personalized care. I know my colleague here will be very interested to know that because lung cancer care is driven a lot by targeted therapy. And it's very difficult to continue treating your patients when you're not able to demonstrate the drivers in those cancers. What we need is strengthening how we collaborate and how we work with one another to be able to optimize the resources that have been made available at our disposals. Yes, thank you so much.
Dr. Murray, after receiving support from quite a number of experts, do you have any change? In 1 minute.
Allow me to start by saying protocol that Director General and Commissioner High Table, we are glad to have you in the room. What do I have to add? I think you asked whether I talked about the communist cancers in children. Now, friends, children are that category of the population we can easily forget that they also suffer from cancer. I say that at Uganda Cancer Institute, 10% of the patients we treat are children. And every year we receive about 700 children newly diagnosed with cancer. And I can tell you that probably 10% of the children in Uganda that have cancer. So whether you are a father or a mother, a health worker, think about cancer when your child is sick as well. It's also very easy to think that children don't suffer from cancer, but there are cancers which are specifically suffered from by children, like retinoblastoma. No adult ever suffers from retinoblastoma. Retinoblastoma is an eye cancer. So what am I saying? Let's also remember that children suffer from what? And at Uganda Cancer Institute, in the National Cancer Control Plan that we have written, we have made a chapter specifically for cancer control in children. The aim is to make sure we don't forget children. Now, one thing I really wanted to add, I know 1 minute is over, is that from what we have discussed, let each one of us find our role in this business of fighting cancer. I pray that none of us will say government, doctors. No, from what we have talked, you now know your role. I didn't know that women can even check their own cervix before they come to hospital. Of course, they have to make sure their fingers are appropriate. Thank you very much.
Okay, and maybe as we do strategies, we don't forget
Okay.
retinoblastoma,
What
one
is
of
that?
the cancers that we can prevent in children. So those strategies should really highlight it. Thank you for
1, 2,
bringing
3,
that up.
4, 5, 6,
So dear
8.
delegates,
That's what I wanted
allow
to.
me to conclude this session by recognizing the presence of our dear guest of honor.
1, 2,
We
3,
also
4,
have
5.
amidst we have
1, 2,
our
3, 4, 5, 6.
DG,
Yeah.
Dr. Charles
This one is 6.
Lara. We
Oh.
also have our commissioner,
Rather buy this. That's
and the chairperson,
careful.
and we have
Mm.
many other distinguished guests that came in as we were in the middle of this heated session. I know we can't exhaust the talk around NCPs, but one of the things I've learned from here is that there are quite a number of NCPs, including those that we think are known in our community that we can actually prevent. And we have tried to do a number of strategies to address these NCPs, to try and identify them.
Who's the Labatella?
The panelists. Thank you for emphasizing those
That is good. I'll give you a verbal.
that are easily implementable as we go out to improve on our early detection of these NCDs. You can now take this. At this point, I'm quite honored to invite one of my role models and mentors in the field of pathology, and one of the strongest ladies I know in the country. Every time we are talking about NCPs. And that's our dear Dr. Susan Nawada. Kindly accept to lead us in this next session. As all of us have the programs, we are going back to our opening session. Thank you so much for being nice delegates, and I hope I get to bore you in the session. Dr. Susan, I can imagine I'm Dr. Veronica. Thank you so much, Dr. Vero, for leading us through this session. Good afternoon. I know we are going to stand between your lunch, but allow us to take on this session officially opening our third design retreat conference. And we are very privileged to have our chief guest in the house. Our chief guest is supposed to be the Right Honorable Speaker, who wasn't able to attend. She had confirmed until yesterday around 6 when she got an urgent assignment, and she sent us a representative, that's Colonel Dr. Victoria Nekesa, who is the an MP for UPDF, representing UPDF, but also a member of the Health Committee and member of PAC. So she's our chief guest today. Welcome, Dr. Victoria. But she's also a pathologist. Allow me to officially also welcome our Director General of Health Services, Dr. Larry. Welcome. Amidst all the challenges and
Otherwise, we would have opened it at 9 and done our things. But thank you so much for sparing this time, because when we talk to ourselves and we are not talking to the people who need to make the changes and the policies, it doesn't help. Thank you so much, DG. I also want to welcome all the participants that have come in. Chief guest, we have several participants from different institutions in country and outside the country who have consistently been part of this conference since we started it 3 years ago. Civil society, donors, manufacturers, academia, research, patients themselves. We want to welcome you to this conference. We see the attachment you have in this drive of having test and treat for our NCDs. And I want to thank the ministry that has continuously supported and given us a hand to make sure that we drum this up to the moment when we see that we achieve what we want. And that's why we really wanted the Honorable Speaker of Parliament to be here to understand. Because without finances and policies, however much we speak, we can't really get where we're supposed to be. So thank you also for coming to attend, and we really know we're going to have a very interactive conference, and we at the end of it all we'll go back with actions that we shall follow through. I'm supposed to moderate this session where we're supposed to have remarks, starting from remarks from the Chair Scientific Committee that has organized this session, this conference, to give us a summary of what has happened or what has been going on. And thereafter, we shall have our Director General of Health Services give us remarks. We will officially invite our Chief Guest, who is representing the Speaker, to make remarks, and then officially open our third conference and officially launch a few things that we shall do. Thank you so much. And at this juncture, I want to welcome Dr. Weisler to just come and give us a brief of what has been happening. Thank you.
Thank you so much, Susan. Protocol observed. I want to welcome our dear chief guests, the DG, and Dr. Susan as well. You're most welcome to this function. I'll go through so far what has transpired through all the time before you came to this session. I'm Dr. Weisler Ali, and I'm a pathologist. I work with the Uganda Cancer Institute, and I'm privileged to have been part of the scientific committee that was actually behind the scientific work that has been talked about throughout by all the previous presenters from the start. So we had the highlights of all the NCDs that have been a burden, not only to Uganda, to East Africa, but as well big burden to the low and the middle income countries. We looked at the burden that cancer has on our population, affecting both genders. It's not segregated. Cervical cancer being the most common among the females, and then prostate cancer as well, striking quite a big challenge, not only diagnosed quite early, but as well in the management. Not forgetting the children, that most of the time we tend to neglect, or preferably want
treat them as young adults. And yet, this is actually a special category of people who are also affected by the different NCDs. As we looked at some of them, they are non-segregated, irrespective of age, be it cancer or other non-related NCDs like diabetes and the rest can as well affect them. So, distinguished guests, we also had a chance to review the statistics of the population of this country, where we had almost 50% of the population being young adults. So this one does not only show us that we have energetic people that are going to carry forward the work that has been done by our four grandfathers, but also gives us an opportunity to see where to tackle, especially when we want to combat the burden of the different diseases, be it the cancer or non-cancer. So with all these burdens that we have from the different NCDs, the cancer and the non-cancer, we looked at the different advances that have also been made in order to combat the burden of these diseases, ranging from the improvements that we have achieved, not only in diagnosing them early, but as well in treating these different NCDs. And this, some of it has been highlighted by the panel of the different presenters that we actually hear. So we also looked at the support that the government has actually put in trying to combat this burden of the different NCDs, be it cancer or non-cancer diseases. We know the government of Uganda has invested in quite a lot in actually establishing and equipping the Uganda Cancer Institute and also the rest of the regional centers that are actually pivotal in combating especially the burden of cancer within the country. That being said, we also have other non-cancer related NCDs that the government has actually also invested in quite a lot, not only in human resource but also in structure, and it is continuing to do so. Take a look at the Uganda Heart Institute. It has gotten equipments, we're able to do some of the surgeries now, and the government is still looking at actually regionalizing some of this care that is going to help and combat the burden. And well spoken out, most of this work is actually rhyming within the themes that we have actually for this conference that we have today. Looking at the burden of these different non-communicable diseases, we realize there are a number of risk factors, which include those that we can try to modify and those that we cannot actually modify. And the government of Uganda has actually done quite a lot. And when you look at the risk factors, we realize most of these risk factors cut across both the cancer-related diseases and also the other non-cancer-related diseases as well. So this one actually implies to us the reason as to why we should actually integrate services within one another, especially if we are going to combat the burden of the different NCDs. And to that, we also came to realize the importance of actually having or reactivating some of these wellness clinics, because we realize most of the things that actually cause the NCDs or risk factors are things that we can actually try to capture, especially with the different wellness clinics. Last but not least, we looked at the importance of also actually integrating research into these management and if we are to combat the burden of the NCDs. With research, it does not only help in bridging the knowledge gap between the researchers and the different diseases that they're trying to research on, but it also actually plays quite an important role, especially in laying down some of the policies that can help actually in combating some of these NCDs. A lot has been said, and a lot more is going to be said, but that was just a preamble of where we actually started from and where we've so far reached and the fact that we are going to go. I will not take a lot of time, but I would rather want to invite Dr. Susan once again to take on this session. Thank you so much.
Summary, and thank you so much for chairing the scientific, for taking leading a scientific committee to make sure that we choose the abstracts or the presentations that cut across right from diagnostics to treatment to community patient care as we see how the agenda goes. Our chief guest and DG, as you've heard, a number of NCDs have been discussed that cut across all population. We are very excited that we are here to see people who are going to really, we are eagerly waiting to hear from you to see how you can support our initiatives in making sure that we combat NCDs. At this juncture, I want to welcome our Director General of Health Services to make his remarks, and thereafter I will invite the Chief Guest.
Thank you, Dr. Susan. Good afternoon. I want to confirm that people are there. Good afternoon. Thank you. The Right Honorable Speaker of Parliament of Uganda, who is represented here by Honorable Barbara Nekesa. I have not seen other members of Parliament. I want to recognize them. Representative of our development partners, from the academia, civil society organizations, from the different health institutions, from the Ministry of Health. First, I want to thank the chair and his team, scientific committee, the participating participants and delegates from other countries. I also want to recognize the members online. Ladies and gentlemen, I think I've missed the community and the patients, all the people who are living with NCDs. Ladies and gentlemen, I suppose our Susan indicated I was supposed to be here in the morning. I've given many commitments, but we saw that we should be able to join you. And I want to extend my apology to the guest of honor because we had to ask her to adjust her time to come. I bring greetings from the minister and the PS who are on other duties, and specifically today, I want to thank you for the consistency for organizing this Africa Test and Treat. This is the third one, so I want to congratulate you for that. NCD's cost discount economy 5.3 trillion Uganda shillings, which is almost about $1.4 billion, which is equivalent to about 4.1% of the 28 GDP of this country. So if you look, if you are one who loves figures, then you can take it in that direction, so you can be able to go to be able. So I'm looking at they seem that unite by the unique placing people at the center of care, and urges us to unite our strengths for equitable health solutions. And so that's why we are looking here. So there are three key things which are from the very beginning, which we need to apply. So
I don't know if I'm the one not hearing anything, but maybe the host can clarify. I can't hear anything.
Yes, we offer them treatment, but the outcome is what? It's poor. But probably if they are come early, then you do what? So if you do screening, then you put them on treatment, but also the other aspect that we do community and individual awareness, so that we can be able to do that. So NCDs, diabetes, cancer, cardiovascular, and mental health definitely have public health emergencies, and all of you know about that. So as we look at it, yesterday I was also attending another scientific conference, and specifically speaking to diabetes, and you see the numbers of diabetes have been doubling over the years from 2014 and 2024. But what's most interesting now is that the International Federation, Diabetes Federation, has recognized another type of diabetes, which is type 5 diabetes. So you need to be, and we do not know what's the magnitude. So this type 5 diabetes definitely is for individuals who are primarily affects lean and malnourished people. So you shouldn't be able to look at that if you want really to slim, or to become lean, and then you become malnourished. Those initially we thought only it's diabetes for the people who are obese. But now you find people who are lean diabetes. And particularly adolescents and young people. And young people are the ones who are diabetes. So what happens here now, the mechanism is that there's not the pancreas does not develop, and then you have no insulin. So we really need to be able to look at that. And sometimes some of it definitely also comes from gestational aspect. If you are born when you are young, when you are small size, and then put on weight, and then later, there's a high risk of you developing diabetes. So probably it's of interest for you to ask your moms at what weight they are born, so that we can be able to track your risk factors. So definitely there is need for us to address NCDs and combat. But also, the type 3, which is linked to and it's mainly by the brain. And then type 4 is mainly now just like they are not in the type of brain, but they have a little power. So we need to be able to type of life. So really, you can't control that. This you can deal with. So as the ministry, we deal with work, community. So we need to coordinate the policy and national regional framework. And that's why the ministry is investing on sugar cancers. So that all those people become the other cancers to collaborate. And I expand the spectrum, not only treatment, but also aspect of education, aspect of violence, and aspect of. So So we need to enhance community prevention and promote awareness, lifestyle changes, which reduce risk, reach the underserved populations, and ensure equitable access in rural and lower income areas. Definitely, there are other aspects of cancer such as the virus, and for one of them, the hepatitis B, which is the hepatocellular one. And yet, I have vaccines available national medical stores, but people deliberately, all this knowledge, do not have one come and do what? Get vaccinated. And yet, we will probably be able to all now, that's why we're also rolling the newborn one. First dose of what? Of hepatitis, so that you can be able to get this children vaccinated. Because if you do that, then you are able to address all this burden of what? Of cancer. Reach underserved population, ensure equitable access in rural and low-income countries, stressing diagnosis, improve early detection, and definitely the challenge which I come to Susan knows, talk to her. How can we be able to telepathology for some of the samples? So what you need is somebody from just be able to prepare the sample, probably read it from there, and the sample can be read from. Probably it might not be an investment where you need to put equipment, same equipment across one. But progressively, probably from the beginning, can do telepathology. You can read the sample in a pathology across the floor. So we need to be able to ensure accessible treatment and advocate for affordable and be able to. I expect that by the end of the 3 days, we will launch the NC research agenda. But we need to do what's relevant research. Yes, you can do the research and you should be able what and if we do that, then we need to actually be able to have an interface with the research institution so that to point and be able to implement. Because if the research is saying just consuming a certain amount and quantity of salt, then the risk of GI, some of the GI might. But have we told people about it? We will not. Or even as the room are telling to do hard so it has effect apart from hypertension and all the hypertension. Also has but we have been able to do that. There are so many tumor markers which now we can be able to do that.
Do we apply those services? All these machines are like them, idle, and probably since we don't have the speaker is here, only the members of Parliament want to fly out of work. When some of these things can be done, here. Actually, most of them, people are aware that most of these tumor markers, you can be able to put them in other cancers at a very affordable and low cost. We need to promote personalized screening and testing. We should be able to have that. Baby machine probably will come and have the excellence. Now the PhDs are also armed up with glucometers and this machine. Can we be able to do that? Can we use opportunity? Sometimes I have had issues with the community health department of the hospital because for them they are looking at the community outside the hospital, but the hospital is a very big community because there are all these attendants, patients who are coming. Do they get opportunity to be screened for some of these incidents? So on the NCD framework, I think there's a framework that was launched by the East African countries. Are we being able to discriminate? So we need. So for us, we're talking about the HIV side. 95% know their status. 95%
years down the road, they have not tested again. It doesn't make good what? Make good sense. You should be able to test regularly and be able to what? Be able to do that. Women examining their breast. Men going for a test. Self-examination. Others sometimes want to make fun and probably the other partner can help, but probably might not make a very good opinion whether there's a mass or whatever, but for you who are paid to have breast every day, you can be able to say that probably some abnormality one. You need and seek care early. By this, most probably to have the statistics here, to visit Women Hospital, Uganda, Cancer Institute, to find that mammography is one of the equipment which is low, the utilization is very low. And if this equipment is what is available, so how can we make people aware that they can be able to do this test? So people need to be empowered. This is to be part of self-care. Probably I will start with those in this house so that if you get converted, then probably you can convert all others. Because sometimes we are very good at preaching, and then when it comes to practice, we practice something different. So I want that when we come in here, we do that. Advocate for affordable diagnostics, so we will be able to see how we do that. Wellness laboratories or clinics, so that people just once in a year, you should be able to get on into a wellness clinic and do a full body check, so that you can get a new bill of what? New bill of health. My fellow men, I am told as only until when in public need to be carried because we want to be strong as men. You want? So that's why it's mortality, morbidity are really, the statistics are not one. Then we say the women are living longer, but we're not seeking one. Seeking care. So I really call on men, let's do that. We need to integrate NCDs. I think we have not done it now. We need to integrate NCDs, other community bodies, and be able to see that cancer screening to HIV, hypertension. We'll be able to look at that and be able to do that. NCD data, are we looked at all the indicators? Are we interested ourselves on the indicators which are in the health management information system? And how often do we analyze one? This even at facility level or even at national level, how do we look at it? So that we just don't look at it as a figure, but it represents one. It can be able to, so that we can use it as a surveillance. You know, sometimes when we talk about surveillance on the public health emergencies, but even in the NCD, these are public health emergencies. We need to use this data as a surveillance, and I hope each of us will be a surveillance officer and be able to do that. We must build regional coalitions to empower grassroots leaders, community health workers, local councils, and youth to lead prevention efforts. Community-based screening, I have mentioned about that, education and referrals through village health teams. And definitely, we had anticipated the W25 by 25. But I don't know whether I will achieve to reduce NCDs by 25% by 2025. So we're talking it almost at the tail end. So probably might have to recast it. 25 by 30, probably now I've reduced it by 20, 30, by 25%. So we need to be able to look at it and ensure that there is equity and making Africa a beacon of NCDs, prevention and care. So we need to be able to do it. I want to recognize definitely other countries who have joined us. We have delegates from Nigeria, we have delegates from Zimbabwe, Ethiopia, Kenya, Pakistan, Rwanda, and South Africa. We really need to applaud them for joining. We need to get affect all of us. So as I conclude, allow me to thank all of you for the organizers and all of you for attending this conference, and what has also given us financial support and technical support to make sure that this conference is held. As ministry, we definitely will look at the recommendations or the things which we need to carry forward so that we do not have the next conference and we speak the same one, same thing, which we have, what are the actions, what's the call for action which we need to be able to do? We need to be able to do next. So this is going to be able to offer an opportunity to forge partnership and innovations and solutions. And I urge you that for the young one, that's a very fertile area for research. There are really many things which you can be able to do here and be able to. Also, I think I missed from China, there was a delegate from that, and other countries which probably are going to mention. So ladies and gentlemen, I was told to make it short, so I want to end there. Thank you very much for listening. It's my opportunity now to invite our guest of honor to speak to us. Honorable Governor Professor, representing the Right Honorable Prime Minister. You're welcome. Let's put our hands together.
Thank you so much.
What's her name?
The Honorable Service of Health Commissioner and Diagnosis Laboratory Sciences, Chair and distinguished guests, esteemed colleagues, and honored participants. I greet you all and called Dr. Nekesa to introduce the background of this. And as member of the Speaker of Parliament, for those of you here as told by the Commissioner, it's my great pleasure to address you today at the launch of the National Wellness Laboratory and Bishop of the third Test and Treat Initiative Conference Against Cancer and other diseases. From the speech that was speaking here earlier, and at the level of the scientific committee and the DG, there are several highlights, and some of them have been that today is a launch of the National Wellness Laboratory in the theme given. This is the first step towards prioritizing health and wellness in our nation. Another highlight is about a commitment against CDs. And this has been heavily focused on addressing the growing burden of NCDs, including cancer now. And the third highlight I'm taking in is about the importance of collaboration, which emphasizes on collective action, collective sharing, and expertise to advance health and wellness. And the fourth highlight from the shared theme is prioritizing prevention and treatment. And this is then focusing on promoting prevention, including diagnosis and enhancing treatment options for NCDs, both calling for increased better allocations to diagnosis and treatment of NCDs and cancer. The highlight is creating a healthier future, which aims at making a meaningful difference in the lives of millions of people in Uganda and Africa at large, and creating a better and brighter future for Uganda's population. This highlights from the collections given is the importance of granting health management, collaboration, and innovation in addressing the challenges posed by illnesses to us as a population and as a community. So on this momentous And also, all these, when collaborated, we collaborate health prioritization, collaborate wellness, collaborate supervision, and these are usually intertwined together all the time. When we do this prioritization, we achieve a lot, we get milestones ahead. I've seen in the blog, emphasis on wellness. This time about wellness is a new arrival, welcome. I think it's great because it's not about the holistic approach. Health that encompasses physical, mental, emotional, and social being. And it's about nurturing and caring for oneself, as been given before self-care, to achieve the state of overall well-being and fulfillment. So therefore, the inclusion of physical well-being, that's from the aspect that I found at home. It's about exercise, nutrition, sleep, and health habits. Inclusion of mental well-being, wellness, as an example, intertwining the tribe. Mental well-being is good stress management, mindfulness, and emotional resilience. And the emotional well-being is about self-awareness. So we talked about the care, treat, and self-checks. You know what's happening to you and also what's happening around your performance in life. The emotional intelligence is coming in, and of course, positive relationships in our lives. And the fourth aspect in wellness, as highlighted today, is about social well-being. That's connections, community, and social support. I brought this up because it brings out a greater spectrum of the care we need to look at, as both proactively and of course dynamically as a process, as focuses on prevention, self-care, and personal growth. Not just the absence of disease anymore. No. It's about the state of thriving and living life is fullest. Therefore, the National Wellness Laboratory is a welcome motivation. It's about representing, it's a force that's going to present a bold step towards proactive health management and empower individuals to take control of their well-being. Moreover, harnessing cutting-edge technology and innovative approaches, this laboratory will provide invaluable insights and tools to promote health living. So in this collaboration, the third Africa Test and Treat Initiative Conference today is a testament to our commitment to tackling the growing burden of NCDs, including cancer. And by sharing this knowledge that we're doing now, expertise, and best practices, we can accelerate progress towards better health outcomes. So I commend Organizing Nawada and the whole ministry and community of Uganda. I commend you for bringing together experts, researchers, and policymakers, and send them today and others from the ministry to address these critical issues. Your dedication to advancing health and wellness is truly inspiring. Additionally, we embark on this together. As we embark on it, I urge us to remain focused on our shared goals, promoting prevention, improving diagnosis, and enhancing treatment options. Together, we can make a meaningful difference in the lives of millions. So, let's harness the power of collaborations, innovations, and actions to create a healthier, brighter future for Uganda and Africa. In summary, Mike Brown is the launch of the National Laboratory and the Third Africa Test and Treat Initiative Conference marks a significant step towards prioritizing health and wellness in Uganda. This initiative aims to promote proactive health management and empower individuals to take care of their well-being. This conference brings together experts to share knowledge and best practices in tackling NCDs, including cancer, and collaborate and innovating and accelerate progress towards better health outcomes to create a healthy future for us. Now back to my role, purely as representing the body institution that allocates budgets and better allocations in science, research, and the ministries and the laboratories. We are looking at in the field, policies for allocation and entries, and we need to look up issues that have been arising and what we've done collectively and correct. When we began to run to the Minister of Health about laboratory allocations earlier in our term of Parliament, we are getting, I think, about 12 billion. Annually, it was very little, it was really in the ocean. And we've been working hard with the ministry and getting this increase. And incrementally, we've had some increments, and I think this budgetary allocation, what we have on record, have more increment of 2 billion or 100 or so. That is positive. We're moving up that way in allocating money for these laboratories and analytics. And of course, we are also looking at as a commitment labs and diagnostics, where this lies, also looking at increasing accessibility to diagnostics with primary health care centers in Uganda. So that when you go to the lower levels, we still get care centers and not want to have some diagnostics that go through. Not necessarily, not just at the top at the center. So we're working on that and just commitment that we look up every time we sit in a committee. So I'm also a member of the health committee besides being doctor and a colleague. So we have to discuss something passionate about it, work hard collectively, get this better. Also, commit ourselves to, of course, increasing the diagnosis group locations in super specialized hospitals in the regions of Uganda. We have different centers coming up, all everything, cancer, heart, all that in labs everywhere in the regions of Uganda are. So we commit ourselves to getting this increase, and so that people can access that and not come into the center all the time. Of course, we also give support in terms of policy making to the agency, or in this Ministry of Health. We give them support in terms of their policies, and if there should be any, we also work on it with them collectively. And these commitments are on behalf of Parliament and for the surely get down to the Speaker and the Executive Committee to know what we are committed and what we had today. Therefore, with these few remarks, I I'm launching the third Africa Test and Treat Initiatives and Conference Against Cancer and non-communicable diseases. Thank you for listening to me.
Thank you so much, our chief guest. And before you go back to sit, we want you to officially launch our third Test and Treat conference, but also to officially launch the National Wellness Laboratories that we passionately talked about by signing over this. So, and after that, we will welcome DG also to sign. Thereafter, we shall have a group photo. As you hope that the commitments, we shall see the commitments to make sure that we operationalize these national wellness laboratories that we set up. Thank you, DG. I also welcome the participants to come and sign over. Hawa, Jane, our participants from different countries, international participants, we request to come and we hold this launch. Institutions that are available here, please come and we officially own also want to have our patients living with NCPs at this time. So as the other sign, can we arrange for a group photo with our chief guests? Where can we? On the stairs? Sure, you want to? We thought we would have it here to be able to.
We need those.
Yeah. To be able to. I think this is better. To have this background. Can you quickly arrange our chief guests? Can we arrange maybe before we? I didn't have this on the table because we are waiting for this.
Good afternoon. This is how we are going to have the photos. We've organized different groups. So we have the chief guest, together with the DG, the commissioner, and then I will request all the specialists in the house to join first. So all the specialists in the different areas of specialization, please come forward and join our house chief guest. And then, as well as the international community. So delegates from the different countries, please feel free to come and join the chief guests, the DG, and as well as the specialists. So any specialists in the house, pathologists, pharmacists, surgeons, obstetricians, please, laboratory specialists, please feel free to come. Let's do this. Maybe I should come and sit there. These are the specialists. Thank you. Then let's have the National Organizing Committee, as well as our exhibitors and sponsors. This conference has been sponsored by a number of people. We have Prodia Africa Limited, Cefai, CEMAT, Medicine. Just to request the DG, the chief guest, and the commissioner. I request for you don't leave just for the next few minutes. Our sponsors and exhibitors, please, let's do this very fast. as well as the National Organizing Committee. Medicine, Sefai, Semad, Crown Health, Expert Uganda Limited, Hudson, and Land District. Let's come and do this very fast. And as this is getting done, we're going to now have all the participants and the presenters come and have also a moment. So please don't leave. Most of us, I don't know, we need space. The participants, all other participants, if you've not been in any of these categories, please come and also have a photo moment with our chief guest and the DJ. Let's wait for all those who are coming. Please, if you are coming for a photo moment, please, let's be quick. And finally, just have members of the CSO as well as committee representatives. We know this is not about us as health workers, but it's about the community, because if we don't involve the community members, they will not own it. So let us have anyone here representing the community, all advocacy groups, please. If you are not there, let us represent you. Thank you so much. At this moment, we are going to have the guest of honor, the DG and the commissioner, visit the different stores. You can feel free to join them, as we also get to know what our distributors and sponsors are having for us. You can also take a chance to learn what the different companies are offering. You never know. After this, you will need their services. So you need to know where to start from when you need the services of our sponsors and the different exhibitors. Thank you so much, everyone, for coming and being part of this third Africa Test and Treat initiative. We don't take your presence for granted. We are very grateful as the organizing committee. And we hope after this you'll be an ambassador of this initiative, as well as the ambassador of the wellness laboratories in the different regions. So, even as distance, great advantage for visiting the different regions for unique sighting in our idea. We don't have the detail.
As we talk about Thermo Fisher Scientific ultra-low temperature freezers, what's critical to understand is that no matter whether you purchase the standard performance unit or the top-of-the-line TSX unit, you're never compromising on sample security. All units are designed for protection of samples. That is our number one goal in the design of these units. When we look at our RDE or FDE or TDE series in the standard performance, these units are powered by H-Drive. So this refrigeration system is designed for quick recovery after door openings, good uniformity, low energy, low noise. As we move up to our TSX unit, this uses V-Drive. V-Drive incorporates additional benefits from the standpoint of greater uniformity, even lower energy usage, and some additional features that are built in.
Thank you so much for this sponsorship. This function for this conference. Simon, we are very grateful. Vincent, thank you so much. From healthcare, we are very grateful. Next time, Uganda, immediate.
Thermo Fisher Scientific ultra-low temperature freezers. What's critical to understand is that no matter whether you purchase the standard performance unit or the top-of-the-line TSX units, you're never compromising on sample security. All units are designed for protection of samples. That is our number one goal in the design of these units. When we look at our RDE or FDE or TDE series in the standard performance, these units are powered by H-Drive. So this refrigeration system is designed for quick recovery after door openings, good uniformity, low energy, low noise. As we move up to our TSX unit, this uses V-Drive. V-Drive incorporates additional benefits from the standpoint of greater uniformity, even lower energy usage, and some additional features that are built into the unit. scientific ultra-low temperature freezers, what's critical to understand is that no matter whether you purchase the standard performance unit or the top-of-the-line TSX units, you're never compromising on sample security. All units are designed for protection of samples. That is our number one goal in the design of these units. When we look at our RDE or FDE or TDE series in the standard performance, these units are powered by H-Drive. So this refrigeration system is designed for quick recovery after door openings, good uniformity, low energy, low noise. As we move up to our TSX unit, this uses V-Drive. V-Drive incorporates additional benefits from the standpoint of greater uniformity, even lower energy usage, and some additional features that are built into the unit. Thermo Fisher Scientific ultra-low temperature freezers. What's critical to understand is that no matter whether you purchase the standard performance unit or the top-of-the-line TSX units, you're never compromising on sample security. All units are designed for protection of samples. That is our number one goal in the design of these units. When we look at our RDE or FDE or TDE series in the standard performance, these units are powered by H-Drive. So this refrigeration system is designed for quick recovery after door openings, good uniformity, low energy, low noise. As we move up to our TSX unit, this uses V-Drive. V-Drive incorporates additional benefits from the standpoint of greater uniformity, even lower energy usage, and some additional features that are built into the unit.
Coming.
As we talk about Thermo Fisher Scientific ultra-low temperature freezers, what's critical to understand is that no matter whether you purchase the standard performance unit or the top-of-the-line TSX units, you're never compromising on sample security. All units are designed for protection of samples. That is our number one goal in the design of these units. When we look at our RDE or FDE or TDE series in the standard performance, these units are powered by H-Drive. So this refrigeration system is designed for quick recovery after door openings, good uniformity, low energy, and low noise. As we move up to our TSX unit, this uses V-Drive. V-Drive incorporates additional benefits from the standpoint of greater uniformity, even lower energy usage, and some additional features that are built into the unit.
But the Siemens PC, you feel like you're just banging it. It is working as it It is just becoming a thing.
The feel free to look for that. Like I said, we have one 45 piece. So there are 4 electrics that we are over here. And we are going to go on the because you have just 2 seconds, we can wait to go and bring on board. And by faith, and everything. Thank you so much. See you after this.
As we talk about Thermo Fisher Scientific ultra-low temperature freezers, what's critical to understand is that no matter whether you purchase the standard performance unit or the top-of-the-line TSX units, you're never compromising on sample security. All units are designed for protection of samples. That is our #1 goal in the design of these units. When we look at our RDE or FDE or TDE series in the standard performance, these units are powered by H-Drive. So this refrigeration system is designed for quick recovery after door openings, good uniformity, low energy, low noise. As we move up to our TSX unit, this uses V-Drive. V-Drive incorporates additional benefits from the standpoint of greater uniformity, even lower energy usage, and some additional features that are built into the unit. What's critical to understand is that no matter whether you purchase the standard performance unit or the top-line TSX units, you're never compromising on sample security. All units are designed for protection of samples. That is our #1 goal in the design of these units. When we look at our RDE or FDE or TDE series in the standard performance, these units are powered by H-Drive. So this refrigeration system is designed for quick recovery after door openings, good uniformity, low energy, low noise. As we move up to our TSX unit, this uses V-Drive. V-Drive incorporates additional benefits from the standpoint of greater uniformity, even lower energy usage, and some additional features that are built into the unit. As we talk about Thermo Fisher Scientific ultra-low temperature freezers, what's critical to understand is that no matter whether you purchase the standard performance unit or the top-of-the-line TSX units, you're never compromising on sample security. All units are designed for protection of samples. That is our number one goal in the design of these units. When we look at our RDE or FDE or TDE series in the standard performance, these units are powered by H-Drive. So this refrigeration system is designed for quick recovery after door openings, good uniformity, low energy, low noise. As we move up to our TSX unit, this uses V-Drive. V-Drive incorporates additional benefits from the standpoint of greater uniformity, even lower energy usage, and some additional features that are built into the unit. Scientific ultra-low temperature freezers. What's critical to understand is that no matter whether you purchase the standard performance unit or the top-of-the-line TSX unit, you're never compromising on sample security. All units are designed to protect the samples. That is our number one goal in the design of these units. When we look at our RDE or FDE or TDE series in the standard performance, these units are powered by H-Drive. So this refrigeration system is designed for quick recovery after door openings, good uniformity, low energy, low noise. And as we move up to our TSX unit, this uses V-Drive. V-Drive incorporates additional benefits from the standpoint of greater uniformity, even lower energy usage, and some additional features that are built into the unit. As we talk about Thermo Fisher Scientific ultra-low temperature freezers, what's critical to understand is that no matter whether you purchase the standard performance unit or the top-of-the-line TSX units, you're never compromising on sample security. All units are designed for protection of samples. That is our #1 goal in the design of these units. When we look at our RDE or FDE or TCE series in standard performance, these units are
serving in a medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. On other days of blind treatment and nation, medical laboratory is here to bring the love. We no longer guess medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Let us rejoice and be glad, all Ugandans, generation now and the next to come. Medical laboratory is here to knowledge. This is our breakthrough surveillance and through research. Medical laboratory.
And we are going to start. Please come with me and see how things are moving. Thank you so much.
Men and women of Uganda, serving in the medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. On our God bless us, men and women of Uganda.
My name is Babidi Tamal. To those who didn't know me, I'm the PRO of UMLATA. UMLATA is Uganda Medical Laboratory Technology Professions Association, and its main offices are found in Kampala at CPHL. We've come to celebrate the Love Week in Lila City, and we are so excited to start off. The other side is where the occasion is taking place, and we are going to start. Please come with me and see how things are moving. Thank you.
God bless us, men and women of Uganda, serving in the medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. On other days of blind nation. Medical laboratory is here to rid the gulf. We no longer guess medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Let us rejoice and be glad, all Ugandans, generation now and the next to come. Medical laboratory is here to manage disease outbreak through surveillance and through research. Medical laboratory, wonderful profession, the core of medicine. Us men and women of Uganda, serving in the medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore.
Yes, we are glad to have the host of this function, Mr. Alfred Olu Firewood. My name is Babide Tamar, the PRO of UMLATA, and I'm just happy to be in front of the future generation that is from Lila Institute of Medical Lab Training School and Medical and the Laboratory Management Science, right? Is it something? Who can correct it first? Institute of Health and Management Sciences. Oh, Lila Institute of Health and Management Sciences. You see, so I'm in Lila right now, Lila City. Behind me are the students of that institute, and before me is the director and the host of this event of the Lab Week celebrations in Lila City. We want to hear something from him. He's an asset in this profession, not even an association only. He will talk about himself. Me, I call him an icon, and everyone celebrates his life. Mr. Alfred, you're welcome. We want to hear. Let people know about you at least.
Yeah, thank you so much, PRO, Madam Tamar. Before I tell them who I am, I would like to welcome Lila City. The city of the rising. I am called Olu Alfred. Oh yes, Firewood. Yes, I am Firewood. You know, in the Bantu language, firewood is called Enku, isn't it? And just one piece of firewood is called? Yes. So that is how I derived my name. I am the Bantu, whenever they are writing my name, they add U after the letter K. O-L-U-K, but they add another U. So we pronounce it as Oluku. So Oluku in Luganda, in Lusoga, in Runyankole means firewood. So I chose now to call myself Firewood. I am the director, Lila Institute of Health and Management Sciences. Previously, we used to call it Lila Medical Laboratory Technology. This institution started way back in 2003, and it's now 22 years old. We have churned out very many lab personnel, up to 600. So we started the school with a certificate training in medical lab techniques. Later, we introduced diploma in medical lab technology. As we talk now, we have pharmacy at both certificate and diploma levels. We admit those who have completed senior 4, and they must have passed at the grades acceptable by the Ministry of Education. That detail I may not go there in the interest of time. Yes. Then those who have come in for diploma, we admit those who have completed A level, they must have done sciences in A level. Then there are those who had done certificate in either pharmacy or laboratory. We also admit them for diploma. Today, we are celebrating the International Laboratory Week. International Laboratory Week is celebrated all over the world. It takes place in the month of April. But in Uganda, the month of April, for us laboratorians, we are busy electing our new leaders. So we had to push it this week. And today we are crowning the celebration. It started with a march by the students you see behind me. These are beautiful students of the Institute of Health and Management Sciences. We walked around town. We are now in the Mayor's Garden, where speeches are going on. The Minister for Health will be in attendance. Meanwhile, at the sidelines, some laboratory services are taking place. We are taking off blood for HIV, hepatitis B, sickle cell disease, blood grouping. We are also carrying out blood donation. I would like to thank all of you. I thank you for that.
We thank you, Papa, for those good words. Maybe just one small thing. If anyone should, someone seeing you out there, the simple word, and the younger generation. Yes.
Thank you, Madam. To the elderly, please check your health status for you fall sick. Eat well. When I talk of eat well, I'm not saying eat balanced diet. Exercise so that we avoid diseases.
Thank you.
panen mo. Boleh cari mana kan. Mana saja buat mobil ci wo. Mena dia. Mat mitas tak. Komepe cukup ini terori. Eka hotelane dirasi administration nyawawan apoyo din eka agong komuna apoyo din wal maya district level assessments apoyo din in charge may ada tempat apoyo din teach lab papat apoyo din eka otin apoyo din papat eka biar kere unu cedero meya unu papat apoyo din nyawa Erik oke anak berjen mania ayai sap orang yang lolo trong kiri rigno di jawente trong di sai jawente lu bu beri nam itu pikir meko neo anatiu Uganda era sasan cucu tiebe ajo tinggal dia kira dua reke jangan apa bung ngomong ada tuan deng kakak betul yang anu dia kada orang mele ding jadi mi ada ngeo dia jawab besok kuno ni ada ngeo kuno mau apa juga bebor man bebor kan man pun coba awak tadi pengen tahu I have problem with one of my national committee member. She's a public relations officer, Madam Damari. I will also ask her to say hello. And over the get look, 11 Uganda chu di guru baca do bibi bapak atau member
My name is Lasanya Damai, and he's the president of the organization. He's my boss. I'm happy to be in the January to be from my hospital.
Are you into it?
Yes.
Thank you. So my root. Root. So kan ayo Babiria
is
okay lawan Wabio Penano yo eka ajen ni lepan so and Babiria we are giving you the Wabio because Wabio is between thank you put pero atam neko pampusiwa poyo dahada pipire ye popi yo bol tata de kan eka yo te fuera pero kala so ana pipuni fuera baro itu jadi kalau boleh itu Kalau jauh berarti nanti bong. Eka anak boleh ayah berbaik kere. Eka ayah oh. Uling tek. Mana? Itu ciplang ni tek. Jodoh bol, kuit. Eka kado wah. Ana jauh lagi boleh buat. Kina boleh pi. Anu dia buat di bebe presiden nyu ngalo dalam tim buah parti buat. Oh jadi Johnny, mi gano. This speciality presiden. Ayah beliau mabiro, di rumah buah orang ya donyo. Mena Mario, wal dia makanan. Di orang cowoknya, Mario. Mena dia spring office saya dia. Itu mana? Ada begini, jual kredit, POTM. Jual dia bocah asing. Bungki kita cara dong. Sasa. Ame proses berbung. Jual wajah ini. Itu mana? Jangan berkele. Ni sasa poin as dia coba bukan. Wajah Mario lagi. Jika ame upar pas dan dalam. Itu upar ini promosi karya PPJ. Wajah ini bahan dan wajah ini orang mulai yo mela potong Lalu ya deteksi sina kuna sana. Oh, apedo blok kan. Apa ini. Mere. Ada penahan. Opi now ini kubai ya. Opi ya. Rupanya jadi opi anak kubai. Walau buat kawan dulu. Ada jauh kan. So ada nanti. Oh, ini. Kalau dia boro, boleh ruang pilih. Kalau boleh pura-pura ada ini. Buat hari. Dirulah jam-jam hari. Amesi. Ada pilih warna. Amu ini sini. Amu mati sama. Wajah kerja. Ini
the president of the Lab Association, the representative of the Commissioner, National Health Laboratory Services, all the members of the association, the people of Lira City, who have come to access services, and all the laboratory students. Good afternoon to you all. I don't know where I stand, maybe around there, so that I'm well seen. But also I need to ask, you say this is a national function, so which is the correct language to use? I need to be guided. Do all of you understand the word? If you understand the word, you tap your hand. Okay, that is about half. The other half doesn't. You can do that now. Very good. You are willing for completing. Also half. There. How many people speak the word there and those speaking English? Okay, there the majority speak English. Then it means we have balance. English and work. Apoyo Udino, apoyo Nelenugu, Yayada apoyo laboratory, Ameo Yoba Timini, Ameo Bedo, Yoba laboratory. I'm thanking the organizers organize this national function in honor of the laboratory here in Minera District. And allow me also to thank you for giving services to the people. You pick the most critical areas to work on, testing for sickle cell disease, but also donating land. Allow me to thank the donors, those who have donated. Thank you very much. We deeply appreciate. Allow me also to thank you, the lab people, for your meeting lab. Karakter mungkin good lab. Begin na be, amazing munguno. Bien, yotkom, yoyenyi pashu, yominui pashu. Ente kakomi lit. Adoy wori da hatal, ngoi woro meyenyo, ciao. Kai woro meyenyo ciao, laboratory pe, memie kongoa me, yololidi, yotua meti komi. Treating wono, nyomi yang wono, beberu kakare. So there is no treatment that can happen correctly without a correct laboratory diagnosis. So in every work in a medical facility, you cannot do without a laboratory. And that is why it has been the policy and commitment of the NRM government to ensure that we have a modern laboratory in every region of the country, but also good infrastructure and ultra-modern equipment in all the regions of the country, so that when people go to seek for help, they can help immediately. Has also been the commitment of government. Ojago the medical person. And medical work is teamwork. Department usually interconnected. Kadong choyi Kai timu ena yepo bingwa meo komi the choyi treatment. Kita meo tukere. Yo kwata do tete. Ipeya keni ko zina ta di malaria ya koma tia mama awu kure. Ngo kwa do kere da hatal e kopi ngo amemiero uwabiti. Kado aworo bala gihu ye will do a poor organizers of this function. I know you did it in a rush, in a hurry,
but it was very meaningful that you come together as the laboratory fraternity to remember the good things that you have been doing for the people, but also to remember the challenges that you have gone through. It would not be right if I forget to say that even in the line of duty, we have lost laboratory personnel. And it is very risky. So it is a sacrifice. Out in your treatment. So we appreciate the sacrifice. Yeah, don't poor government men una poor Yoweri Kaguta Museveni, the President of the Republic of Uganda. Pitutemera tek merocho yotkom mekelo jama beshwa don menenoni yotkom wa uberatie, and we are economically productive. Jama mero kelo kekeni kare me COVID Paul nagwo jama me ministry me yotkom kare me COVID duong. Dado wan po binu dok chien yena mane ni kan na me ministry me yotkom tiye papatere dok tiye kondo meda anyini. For the entire laboratory fraternity through you, Mr. President, and the Commissioner for the good work that you're doing. Let me wish you very nice celebrations and thank you for using the celebrations to give services to the people. For you, Unumake, for you, Unubino, Wotipolo, and Gumikombo. To ensure that the laboratories are accredited and of international standards. So laboratory ametia tishilira kan ubero laboratory ame standard mere ngeya international. So test ame otimo kan ubero test ame dangu ye kanoro dushu ye ubero test ame ti correct. So mono dushu wo nero akamente ame dan tia tinere now, satellite laboratories are government tier ketro. What we have how many satellite laboratories? 4, 5 only. And one long can come boom. You can take a satellite laboratory. Ero ngewo ni kinoro pe binu amenga toro pe uwo kuyore. Manu ko mieru jonge. One particular regions a para BCM. Laboratory potia piche kene to one ticket. Now satellite laboratory ka yini woro menge yo ye. Inu omu machine na don. Mepi mutuo ikom dano. Nyuruni miri me wot kanu kenne mepi mutuo pedong tiye wero pi mikwene ikan dinoro dusha me yini mitungeyo ame kwa hoko mi wero pi mikan kadi doma mi rifaro ni wori rifaro me yenyu treatment orani wodo nuo tuo ko deko bini tuo ni ene be wero handling ikan amiteni yindo iworoho yo iwot mulabo yo iwot kwene out treating it. Ametini ni anami to puo yo jo ameti laboratory ate hate haineno giatini ni ene. Johnny ene chahere national level. Nenu gitie meneno ni ngara cheli Uganda komio quality tests dango mio quality results ameo mio giutimo supervision naha the lowest level na health center 3 meneno ni gina mautia kimukunu tie correct. They are united with very good teamwork. Ame teamwork gini yere oyabigiyo. Not only itimo tests, but also itimo research. Kede lobbying for more resources. Meneno ni teacher meutia timo tie kakari. Donc kage no celebrating ni na team ni yene. Ameutia lungu ni National Laboratory Day ni yene. Pire tek mepo yogi bigina bera meutio team. Amitu miyungeyo ni nuongo tuo COVID karame odonye Uganda. Pimute ko boni tuo COVID dongeno cha hereni. Gine na yomi wange chere. Yendana me onwo chikere tuo me COVID upiru kere dege de porro wange mako. Ni dano ni chikere liego. Ni dan kera boro. Don kongo pim. Inu de pimute ko biwani tuo COVID tia. Ikare katuo me Ebola tie. Kado wano kwanyo remu teru kodi. Yenu tikere machine me pimu du tuo moro pimu te koboni man tikere Ebola. Dok tuo me Ebola pe pimi cheleken. Beru pimu no wano tiu kokodano ni yo wanga medo koboni tuo pe. Achoka yini beri chua me tuo Ebola. Kudu mede pimi ni yo wanga medo koboni Yisimen Ebola dampe. Kudu gina gino timu. Achoka ino giuti upimu. Nguru were gina pat. Bala jua wot kwere itwe. Meke ngotuono kobo. Dong gina wano tiyo yele yetieni. Umitu ni regions dushume Uganda. Bekele kodi machina tek. Mepi mukodi tuoe. Ame yai ka noro keke na menuo jopeti aniangoni. Mewe kunuong John. Ame Peru nebo ngatora. Now, co-permanent president of Congo. Amedan commissioner of Dohien. Alowere kere jo atia kwano laboratory. Kere jo hamedong ti laboratory. Kong na machiel, wan miro kuo unuka mente. Ameo yabu dogola. Yeni kara chona wanu tiu kwancha. Jo ameo nuo kwanu degree laboratory kere masters laboratory nuo pe except microbiologist. Gamente te yabu dogola no. Mando jo. Na Mario, iyi structure anyen amea wor macha wano moko oyobo tembo dongo te clear yoko laboratory staff tia metununa ha 11 me health center 3 gino don keken very wage them. Then they will all be recruited at all levels. Don chente mechulo salary. Tekikamente omio kutega mujoi teach. Namadek.
I think you have my presentation I share.
His scheme of service. Permanent Commission of Convocare. Oyabo to the highest level. They are even consultant laboratory people. So mono tushido tia boanya. Udongi students ni can make one. And very well, by the way, then you will be recruited into service as the wage bill allows, and you give services to the people. Enti botwa wano tete. Den wano tete rokado en woro. Ka wori ni wori pinremo. Mr. President, we are not interested in the unit and you find you para master. Anami pimuremo na. Kekenmo. Ami tu pimuremo na ami tu treatment. Yempeho na obelu ni commandate. So ena wuli ko buulucha is for you. But for us the otedero. Wano mi tu yotko. Wano mi to correct results. Amegina wuli te me yuwende. Ento, ani chawa ni kadu arubu wara tetero, atikele komi. tie jomori ya kina uwa meka upimo remo tim digi otikere brucellosis typhoid ideme yuwunu jone mwonyo yate brucellosis typhoid amekom gipelite brucellosis typhoid doka yini bela tedero tina meji wini popa kanga torko bini tuo brucellosis meji typhoid gamwara galite dok pashite dok itakatal where tuo nova. That is not true. It is not true. Monubero diagnosis method gente kontano. Kien kayini tuo typhoid at the turn pay what it te wori laboratory Moroccan and no joga mu paitana. Typhoid is not a simple disease. Where ko te do hita kali dungu mi kuri ya tora no luoni ngo where ko Johnny na meti da hataliene apati pimuremo. They have other mechanisms. Jamuken na meuti ukere meye nyutuo no karuberu culturing remo culturing tiki nora me ukeriye ilemna mpangi oka uluoni teta tera nyukimu kuri no uluoni already called culture pita tiki le gino ano tuero pita ude tuo no te doa au te kobuni tuo ene utike de dog gino kena me oberu pipimu PCR opimu DNA opimu enara so ngator pe goli ni tuo typhoid ke brucellosis weru unu ko bammi to test to kenne tie kwene iset like laboratory wu en test no na yo pimma do be kuoli de be gamu chente ni no so commissioner in your laboratory there in the National Health Laboratory, go back and sit down and you agree that the people of Uganda should not be cheated. They should be told the truth, and they should not spend money in areas where it is unnecessary. Kado worba gihu en teacher laboratory ni en kajo atimo ni connecting kere dahatal be yini yai pashu ineta mi weekeni ni mitwot dimuremo yen gina yini wot pim chao kene pe oberu gina mieru yini pim mieru dahatal na yemoki ni wori team test amed beru kiti otherwise ibalulwa hichente ameperi ngewu Ojaho kede medical person. The choyi and give me one of the medical work is teamwork. The department or team American departments usually interconnected. Kado muchoyi the word pin. Kai pimu do ile do ko bonna ta meo cho. Ena yete ko bingwa meo nuoi komi the choyi treatment. Kita meo tiu kede. Yo kwacha doctor go to the there. If ya keni the community na ta wujini malaria tia koma tia na mama te awot people there. But what my local da hata e copy mo amemiero what it is. Kado aworo bala
Happy and happy. Lab professions and everyone out there that seeing us, Yumlata. You know, today we are in Lila City and this met the big people, the legends, the assets we have. I think this one has an asset in the Yumlata and Lab. It's an icon in this association, it's an icon in this profession. I would not say anything about him because I really find it to us so that everyone knows about him out there.
Thank you very much, Damali. I am Mustafa Oluju. I am a composer of Uganda Medical Technology Association. I wrote it, I recorded it, because I take laboratory profession in my heart. I love it. And my desire is that laboratory profession to grow and grow. we should live professional way out. So thank you very much.
Now I can now start the name authority because you've already talked about yourself. Did you want to come up with a song? You know there is a way the rhythm comes. Let me call about three wonderful question. You just want to come up with that. Then the rhythm, then the voice. How did you get any other person? Was it one thing? Tell us about that.
I am a songwriter. Writing this song took me 4 years. I write, I could delete, I could add. You know what maths in mathematics? Yeah. I was using that. You multiply, you buy some what you add, and it came and nice song. And me, I enjoy it. It is not easy for musicians to enjoy song fullness. But this one, when I sing sometimes, yeah, comes. Songs can touch me the same way people outside there. I think it is God who made me write songs. It was not my own.
So you deleted, added, divided, multiplied for
4 years. Then I came with it, and it was passed out from Let's Run Hotel in Morocco. This is going to be unlimited love technology. So that's where it is now.
Did you reach a time when you got frustrated?
Because I was working alone. Right? Writing a song, you have somewhere you sit, you buy sodas, hotels, you don't just sit. What are you doing there? At least buy something, it takes money.
So where are we?
But I am glad that you are recording. Mr.
He's here. This is where he is.
Lira Medical Laboratory Knowledge.
That's his presentation.
Lira School of Medical Laboratory. It is now called Yams. Lira is LL Management Sciences. Yeah. So came up and said, now, I think I have seen what you are doing. I have to support you. And support me now in paying for us.
We are talking about assessing in the profession. This is assessment. I was just excited when I saw him then the name, the voice and the rhythm that are behind the when you are singing it, and you feel like, yeah, this is mine, this is my profession. So, from that time, Mr. Alfred came in. Actually, Mr. Alfred, you saw the band that we just followed. Now that is the person behind all those ideas they are talking about. And I have assets from an asset. Kagame just founder of the day. From that time, from Mr. Alfred, you get anyone fund.
And I am so glad that you have organization at least you have seen some, and you have got I am not telling you. Somebody was telling me was chatting with me. Okay. One time we will see a way of fundraising for you. So that means you also try.
Yes, but I've seen his presentation as well. He has seen.
He was just chatting. If God
wishes as you wish your song go through. Mr. Gagara is always posting. Me every time they post it when they post it in the morning, I tap to sing it again. So just know that when I came, It is a song behind the rhythm of love, and then when you sing it, you feel you're in the right track, you're in the right course. So that's why I should thank you so much. May God bless you. For all these days. And you're going to live beyond that legacy. You're going to live high because it's the legacy that you already set, and it's going to head down. We appreciate as about professionals on behalf of Mulata. My name is Yameda. I did introduce myself and the PRO currently, who is the PRO of Mulata. That is Uganda Medical Laboratory Technology Professions Association. Now when you see India, love this profession. Even have the contract. This that's what now for you even carry it from
sometimes what don't it's very
from now. This is going to be a project for you. Yes. So in terms of awards, we want to tell those we've got professionals like young. They've been told your course doesn't have future. Everyone is doing their own things. We are not going anywhere. There's no money. You are poor. What have you enjoyed in this profession?
No. I am this profession. I am almost tired from civil service, and our young ones. The hope of our future, the hope of medicine, medical about. Now there is there is what? There is microbiome resistance. Now, this time it is enough to take charge, because without that one, medicine will fail. This bacteria so only culture and now get the right drug for the right bacteria. So I'm urging my fellow that is bam. This is a very profession. I love it. You love it. Thank you.
And thank for those remarks. My son began from certificates, So I want to thank them that trusted me with your words. And in this position, serve the patient. It's an opportunity every time you get the opportunity to because it's one thing you're going to serve all your heart, nothing that can touch it is the price that you're going to touch it, but the love and the passion you have in it. So that means everyone that has something that you're going to serve in the interest of the person that you're serving, and see that you yourself the legacy when you live behind, the good one, and the name, and the product. So that's the thing, that we love our patient, and I would encourage everyone, please, wherever you are, be satisfied with the right decision. Love your association, subscribe to it, register, and demand what you expect. Please.
Serving
My name is Babidia Tamal. To those who didn't know me, I'm the PRO of UMLATA. UMLATA is Uganda Medical Laboratory Technology Professionals Association, and its main offices are found in Kampala at City Shell. We've come to celebrate the Love Week in Lila City, and we are so excited to start off. The other side is where the location is taking place, and we are going to start. Please come with me and see how things are moving. Thank you.
God bless us men and women of Uganda, serving in the medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. On other days of language examination, medical laboratory is here to meet the Lord. We no longer guess medical condition. Medical laboratory we cherish and adore. Medical laboratory, wonderful profession, the core of medicine. Let us rejoice and be glad, all Uganda's generation, now and the next to come. Medical laboratory is here to manage. This is our breakthrough survivors and true research. medical laboratory, wonderful profession, the core of medicine.
Where we lie in Christ and this most of these commodities are available. Really about 20%
God bless us, men and women of Uganda, serving in the medical laboratory. Bless us with knowledge and wisdom from above. Medical laboratory we cherish and adore.
We are glad to have the host of this factory, our friend Firewood. My name is Babide Tamar, the PRO of Umlata, and I'm just happy to be in front of the future generation that is from Lila Institute of Medical Lab Training School and Medical and the Laboratory Management Science, right? Is it something? Who can correct it fast? Oh, Lila Institute of Health and Management Sciences. You see, so I'm in Lila right now, Lila City. Behind me are the students of that institute, and before me is the director and the host of this event of the Lab Week celebrations in Lila City. We want to hear
for the oral antibiotics. They are also really available, especially the combination treatment options, given that most of our patients are managed on combination treatments. Then when it came to pricing, we noticed that single agents that were generics were largely affordable. We are priced better, but they are also affordable for Ugandans. However, combination treatments, whether generic or branded, they were not affordable, and they are really priced way above the international price ranges, up to 5%, 5 times the reference prices. The other thing we noticed is that in the private sector, that the stock is driven by preference for newer agents because of the higher profit margin. The lot is actually recommended for treatment in the guidelines, but also in the essential medicine. Yeah, so key insights really to drive from this slide is that essential medicines for CBD are really available, but for diabetes, there is shortage of basic insulin formulations. Then we also noticed wide pricing disparities, which is already an indicator of market failure in Uganda. It means we have a weak price regulation, and so we are failing to dispense equity when it comes to access some of these products. Affordability, medications, like I said, the single agents, generic, were really affordable, but combination and branded products were not affordable. So this is now a detailed table for CBD medications. You can see I'm going to take us through about 2 of them, and then I move forward. So for example, amlodipine, which is on top of our table. You can see that the cheapest pack of 30 is around 3,000 shillings, and the most expensive around 33,000 Uganda shillings. So you can see the lower end is really aligned for a person earning a minimum wage. However, like I said, generics are not widespread. Most of them are not even in the private sector is branded, which means that most patients will not access the generics easily. And then you can
Yeah, so combinations, for example, amlodipine with thiazide diuretic and so on, those ones are way higher, they are priced way higher than the international price range, so they remain out of reach for most of our patients. So you can see that fixed dose combination pills are really priced beyond their affordability threshold. And then for diabetes, what you can take out from here is that human insulin in the private sector is not affordable at all. So the price range is from 7,000 to 250,000 per unit pack of human insulin, whether it's a vial or a pen, which makes it really out of reach for patients. But when you compare the price of insulin in the private and public sector, you can see that NMS's price range is actually affordable. But we know that most patients never get sufficient supplies from public sector. So they will talk about their needs for treatment from the private sector. So this is why we see, I think, patients coming in with complications of PKA, because they are not controlling their sugar levels. Because the supplies are expensive, where they are going to purchase them. So we, what are some of the recommendations? This is my last slide before we have a discussion. So we are saying there is need to promote generic availability, generic food in the private sector to ensure equitable access to some of these medications. Number 2 is drug manufacturing, which is, I think, already happening, but for NCD medications, drug manufacturing is still limited. This could slash most of the money that goes into markups for these products. The other thing for diagnostics, I was moving around, actually saw diagnostics. There are some items that can be pre-packaged in Uganda to slash some of these costs. For test kits, for example. And then the other thing is, like I said, there's no price transparency, there's no price regulation. So we can also initiate discussions with the private sector around how we can regulate prices. I know there are policymakers in this room, like South Africa, like Sudan, like Mali and Burundi, and Tanzania. For essential medicine specifically, they regulate markups. There is a maximum price at which you cannot exceed, and patients are accessing this. And then transparency. So some countries have databases where a patient can go and actually check the different outlets and the prices on some of these products, and then they can choose to go where it is affordable for them, which is lacking currently in Uganda. And I think NDA can spearhead this. And then, of course, enforcing cost-effective generic-oriented treatment guidelines. Now, we know, especially the clinicians in this room, that generally guidelines are supposed to prescribe using generic names to improve on access. But that is not happening, especially the private clinics and hospitals. And I think the pressure is coming from the marketeer, the big pharma, and so on. And so we tend to think that generic versions are a bit inferior to branded products, which is not really the case. It's not always true. And then the other thing is to advocate for insulin, for insurance coverage, and chronic care support groups. So there are some areas in Uganda where patients have formed support groups. They pool resources together, and then they procure with the support of the healthcare workers meet the needs that the public facilities cannot meet. However, this has been encountered a lot of resistance because they don't have a legal framework. They don't have a policy to support the establishment of such groups. But we can, like I said, we have work and influence policy. We can expand the formation of these groups to make sure that we increase access to some of these medicines. public partnerships. These are still weak in Uganda. Here we can look into things like food procurement for some of the commodities, to be at cancers, because, for example, cancer treatment centers in the private sector are really key. So if UCI could lead, a consortium of sorts, and then they just consolidate orders with the private hospitals, and then get competitive prices with the suppliers, that would work, and increase access. But there are also other things, like I said, working in the private sector to regulate, find out competitive pricing, and be transparent so that patients can access these commodities. So I'll end here, and then I'll open it up for discussion.
Thank you so much, Dr. Hassan, for that wonderful presentation. Let us appreciate you.
We are not sharing the screen with him. I've even allowed him to share his sharing.
Oh, thanks. So, just interruption. I know this is, when someone, like I say, every time we finish prescribing a patient was, how much does it cost? Where can I get it? And this, all these are going to be what? Affordability. Even last year, even those that you think are going to write research scheme, how much does it cost? Those one needs to get how much they want to spend on this. And because this is a serious issue, we join the panel in this discussion and we will welcome Mr. Patrick Edet. Patrick Edet is representing the ED of NACAS. He's going to tell us what NACAS is in full and what they do and how they influence, they are trying to overcome the issue of barriers. The other panel that we're supposed to have is Mr. Christopher, who is the beauty, who he has left.
Okay, hello.
Hello.
Can you hear me?
Yes, we hear you.
Okay, I'm about to present, right?
We will let you know.
Thank you so much, Mr.
Okay.
Edet, for joining the panel. And before we move any further, we've known that at least we know Dr. Aston Wangila. So we should ask Mr. Edet in 30 seconds tell us, just as we about yourself, from the discussion.
Thank you very much, moderator. My name is Edet Patrick, as has been said by him, the ED National Cancer Awareness Organization. Now, in 2010, we are among the group that championed the awareness in this country as far as cancer is concerned. I lost my father due to prostate cancer, in 2015, after he died at the Uganda Cancer Institute. And the reason was he was diagnosed dead when the cancer has already spread and metastasized deep in the spinal cord. And therefore, there was no treatment even he got. He was just sent palliative care because it was too late, stage 4. It was already spread different deep parts of the body. Now, it is only unfortunate that we were discussing about diabetic drugs and then cardiovascular diseases. I wish it were also included cancer, because that's my area of concern. Because I know many patients at the Uganda Cancer Institute, after diagnosis has been done, the prescription has been done by those oncology doctors, then they will now mark the pharmacy at the Uganda Cancer Institute. how to define drugs prescribed depending on the type of your cancer, the primary body part where the cancer is developed from, and the general health of the patient. Your leaders have to define medicines prescribed depending on the three are available in the Constitution. So what next? The two, you're supposed to go and buy from outside pharmacy. That's where the challenge comes from. And sometimes, like my parent, my user he was on Zoladex. I believe most of you know, Zoladex is a single dose. The cheapest we're getting at Ferica Pharmacy was the 900,000. That was the cheapest. And he was supposed to be on that one after every 2 weeks to control the cancer cells. So, I think I will need to invite some patients.
Yes, thank you so much, Mr. J. You guys take your seat.
Thank you.
That is, so from our always we are the better we are with the right people. He has lived experience with the issue of pricing. Maybe I'll pick it from there, Mr. Edith. So from that experience of buying the drugs at 900,000 per day for using for cancer, do you think, are there government policies that you think that can help in regulating these prices? Or you think there is way enough the government can?
Thank you very much. You see, at least for me, for us as a family, we could afford it because we have an upper hand. But there are patients that come from those hard-hit areas who are sold 2 goats because he knows that when you come to Cancer Institute, everything is free of charge because the government facility. Now, the policy on medication or on cancer medicine or also on this other one we're discussing about is that it is from the Ministry of Health policy. I've tried to study, there are policies there, but the implementation is the problem. From the Ministry of Health, then they will take you to Parliament, education, then from there, the NMS. So it's a full spectrum of all these institutions that are supposed to make sure to ensure that medicines are available. So for me, as an individual, I will need us to really revisit the policies on how drugs are supposed to be beefed in our hospitals, especially at the National Hospital or General Hospital. Because that's where things start wrong. Even if you ask a doctor, doctor's hands are tied. He said it is about policy. Minister of Health policy will have done the policies. But the challenge now is that Parliament is good at what Madam Honorable who was here, I wish she was there. So things that's why he talked about the budget. You be increased, especially for the social medicine. Cancer medicine from
Thank you so much. Let's give the person the microphone, the pharmacist. Dr. Aston, we know that the government has good policies, but now you are here as a pharmacist. We know these drugs are manufactured here. The government gives waivers or investors that come here. Why are drugs so expensive? Do you think there are some strategies that as pharmaceutical companies are missing as far as pricing of these drugs are concerned? Or even as the manufacturer, zero is manufactured, then the suppliers they can use it to do the equation in the pharmaceutical sector.
Thank you. So I'll talk about 2 things. One is that we do not have, currently, we do not have policies that provide for price regulation, especially in the private sector. Ideally, we are supposed to have a level of transparency where the people who manufacture these medicines, they disclose what we call ex-wax prices, the price at which you get from the plant to the manufacturer, and then the markups down the supply chain are also supposed to be transparent. So, however, that is not happening. That is not, we do not have that in Uganda, meaning that if I am a private sector player and I have a wholesale pharmacy, for example, it is up to me to actually determine the price at which the patient will procure the medicine. Yes, I understand it's a free market economy, but I think government still has an obligation to intervene and ensure that
price their commodities the way they want because there's no regulation. And also they are not required to disclose, the cost price, the price at which they procure some of these products. So it's really challenging. Again, like it says, it goes back to policies. If there are no policies in place, then you cannot hold anyone accountable. But also the other thing is that we need to enforce. We can have policies in place, but we are still having challenges with enforcement and the policies in place. And also, we are lacking in our engagement with the private sector because I am sure the private sector will be ready to listen, especially when we come up with programs that benefit both the public but also them. So I am seeing manufacturers, for example, in this room. Last time I was having a conversation with an individual from Medicine, I think, on some of the products manufactured by Roche. I think it was recombinant and recombinant strips. So we want to see how we can scale because their products actually are affordable. So we are looking into scaling those public sector conversations, but you could see that if you engage people, they are always willing to listen. You promise them volume guarantees. Yeah, but those are conversations we are not having. So I think it's high time we start such conversations with the private sector and see how we can improve access for some of these commodities. Thank you.
Thank you so much, Mr. Aston. When you say that manufacturers need to be transparent in their pricing, it might know the comment made by one of my friends who said that honest and profit do not come in the same sentence. But when you are honest, forget about profits. If you need profits, we need some profit. Honest, I need to know how that works. But as we end this session, decided, I know you've been to the community level, you've had this and the lived experience. What are some of the innovative ways that you think can help improve this challenge of affordability of these drugs, be it cancer drugs, diabetes drugs, and other cardiovascular drugs? So at community level, what are some of these innovative methods?
I think as you have alluded a bit, that in this discussion, I think it is high time for us to start forming some of the associations in the community where patients can come together with other well-wishers. Because cancer does not segregate, whether they are young or old, whether they are from the east or north, dark skin or it strikes equally. So we need to come up with the associations so that we call on a number of other well-wishers, so that we can have a formidable force that when you use. I saw it in Kenya when I visited the cancer center in Kenya. Even people have created WhatsApp groups in order to engage communities to contribute towards stocking these essential medicines. So I think as a country, we were here, we need to take this agenda ahead so that we can help deliberate on what government is doing. There are people who still well-wishers outside there. Cancer today, even right now as I'm speaking, I have a patient who has died yesterday from the Cancer Institute from my family again. Actually, the body is being transported right now. I've been engaging with them. But for that mama, throat cancer, she did not even get treatment at the Cancer Institute. Why? Because the body was already weak when they did all the diagnosis and then LFTs, RFTs, CPC ones. She was already weak. So doctor said you cannot put her on chemotherapy because we had her die very fast. So I think that's number one. Then number two, I think as he has alluded, we need to talk to the private sector. The manufacturers and the distributors of this medicine. You are all human beings. We are here for one another. The Bible says love your neighbors, love yourself. So we can always create a way on how we can engage the private sector. The manufacturers of this, they are here in the house. To really see how we can really get this medicine affordable.
Thank you so much for saying it. Dr. Aston, as we conclude this, from the manufacturer's point of view, the distributors and other pharmaceutical companies, place that can help evaluate this skyrocketing prices. Because really, I don't wish to go buy paracetamol daily. Here at 1,000, I go to State Center, it's at 5,000. So what are some of the innovative ways that you think can put in place so we can come and overcome this challenge?
Thank you. One that comes to mind is access pricing. So access pricing is where a manufacturer comes up with a program where they are willing to significantly cut down the cost of their commodities if an entity promises them large volumes of consumers. So I would again say to the manufacturers that it's high time they have these discussions and these programs, and then reach out, because we have entities in Uganda. We have NHLDS that is leading the laboratory arena. We also have national medical stores, we have joint medical stores, there are warehousing and distributing some of these commodities, but you also have other players in the sector that can actually influence the consumer landscape and provide these volumes that could match to the demand for these products. So I think we need, as manufacturers, they need to create access programs where they will make some of these products very affordable for Ugandans, because in Uganda, like we have seen, the burden is really high, and the demand for these products is high. But because of the affordability issue, the access is usually bad. So I think, for me, that is really on top of the list. Coming up with access pricing programs to make sure that Ugandans can afford some of these products. We've had some in the past, we've had, I think, Novartis. We've had some manufacturers buying into this idea, and they have supported millions and millions of Ugandans in some of these products. So I think that is one that I would recommend.
Thank you so much. I'm hearing you very loud and clear that instead of giving people land, tax waivers, should instead give them big practices. Thank you so much, our panelists. I would wish to just get two questions from the audience. One from the gentleman and another from the lady. I see two gentlemen who have put up their hands. You also will not ask the question.
Thank you so much. I really acknowledge and pay respect to the elders under this roof. I salute you all and greetings. My guy Hussein is my name, and I'm a neurologist and I'm pursuing a PhD in the same area. Indeed, what I've talked about Ugandans, where I'm also inclusive, we've done a lot of preaching and best practice. I don't know whether we have a representative from Rwanda. I'm just not asking a question, but this could be an initiative. I went to Rwanda, I think, this month, and they have a scheme called the Mutule Descente. It is an insurance where they pay 3,000 to 7,000 annually. And this insurance covers the basic, primary, and secondary treatment. And I think this could be some of the initiatives we could actually benchmark from just neighbors here. The simple insurance, someone pays 3,000, and I was also surprised when somebody presented the study, and they had more than 90% of their participants under NCPs having insurance covered. So personally, I'm thinking that could be some of the ideas. And the other thing is, indeed, practice can follow policy. We could have practice in these institutions. These are big institutions. You're not an institute, you're not a cancer institute. You can come up with a practice. And so doing, then they can be a policy, maybe modified or adapted. But the issue of policy, we are not policy interpreters. We better practice, and then the policy comes forward. That is the real world practice.
Thank you. Thank you so much for these great ideas. I think insurance has been a song national insurance everywhere, but also those of private insurance still without any cities covered. Any other person with a question in the audience, before I the female? If not, I'm going to give all the chance to replace it.
Thank you very much. I have a comment as well as a question. The first comment goes to us as practitioners when it comes to prescribing. Of course, it's recommended that we do prescribe the medications, but we find that I don't know if it's the marketeers that bias the minds of the prescribers to end up prescribing brand names, which in turn becomes a challenge due to affordability. Okay, my question is, when you were doing this study, I don't know if you looked at, because you find that people have a myth that they attack, they think the more, the higher the price, the more effective the medicine. So they know if you tell them this drug costs 5,000, and then there's another drug which costs 50,000. So then they will think that one which costs 50,000 is more effective than that of 5,000. So I don't know if you found out this during the study as one of the issues that could bring the affordability down, because you may find someone can afford that drug of 5,000, but can't afford the one for free, and they end up being considered as unable to afford. Thank you.
Thank you so much for that question. Dr. Caston, could you answer in 30 seconds?
Yes, thank you, Dr. Isiko. Yes, it was actually 70% of the products were branded, 30% were generics. And like I said, in the private sector, two things drive stock levels. One is the profit margin. Two is also the demand from the general population. So I think over the years we've preached a wrong message of foreign brands work better than local brands, or branded products are actually superior in efficacy to generics. So even the communities now know this to be the case, and pharmacies will stock the branded products because it's what the patients will come for. It's what they will eventually procure. So yeah, it is true, and I think we need to go back to the drawing board and rightly inform our patients about how medicines work.
Thank you so much, Dr. Aston. Mr. Edith, in 30 seconds, do give us just a few words as we finish up this. Just 30 seconds. Give us words.
Thank you. For me, cancer or this non-communicable disease, the reason why we're gathered here, it is for these NCDs. It is real, these diseases are society, they are with us. Each and every one of us has a mandate to do. So in your area of specialization, please let's try to go back to our various institutions or communities where we come from to start implementing something a little can start. They say a journey of 1,000 miles starts with one step. So I think we all have something, a role to play in one way or another as we are trying to close the gap in these NCDs that are becoming a problem, especially the sub-Saharan region. And also the issues of diets, nutrition, also need differ. Because nutrition goes together with the treatment. A patient is on hard drugs, they have put a chart there, you eat like this, a pyramid, eating well-grained food, you even a lot of the money. So it's a whole procedure. You see, when you are training the American Cancer Society, we looked at the three aspects in cancer management. Awareness, diagnosis, patient navigation. Now, as a country, we are focusing on management and probably on palliative care. So the rest of the major ones is why we are here. So I think, in conclusion, all of us have a lot to play. So let's go outside there and implement a little of share here and learn from you. Thank you very much.
Thank you so much, Mr. Ebeda. Dr. Aston. Let's give them a round of applause. Thank you so much for participating in this session. So we're going to have this, we're going to be looking at the differential gene expression analysis between breast tumors with wild type and mutant P53, as well as BRCA1 and 2. And to take us through this session is the Tendai Zenda, who is a 5-year drug discovery student at the University of Zimbabwe, with a deep passion for interpretive phase and metabolic research. He's an intern at NTC Tendai, and is exploring the potential of natural compounds in medicine, blending traditional healing practices with modern science to involve innovative treatments. He has a strong interest in medicinal chemistry and pharmacology, and is also committed to discovering safe, effective solutions that improve health care. He is driven by the curiosity and the desire to make a meaningful impact, and also he aspires to contribute to groundbreaking research in drug discovery and integrative medicine. As the audience, let me welcome Mr. Zenda, who is presenting us.
Yes. Can you hear me clearly? Hello, can you hear me clearly?
Yes. We hear you.
Okay, thank you for the opportunity, and let's get started. Prostate cancer remains a significant global health challenge, particularly here in Africa, as it still claims about more than 300,000 deaths each year. So today I'm going to talk about an innovative approach to supplement the existing efforts to fight against prostate cancer. And before I get into the details, allow me to give a brief background so that we understand the problem that we are trying to solve. So prostate cancer is the cancer in the prostate gland, and prostate cancer is the second common cancer among African men, with high morbidity and high mortality, affecting more men of older age. And some global initiatives have been playing a very crucial role in the management and the treatment of prostate cancer. And the existing therapies like docetaxel and enzalutamide have been playing a very crucial role in combating prostate cancer. But however, those therapies are associated with severe side effects and with the narrow therapeutic indices, as well as they are inaccessible to the general public domain. And this marks the need for alternative therapies which are safer and offer targeted solutions, and to at least supplement these existing efforts. So zinc and copper nanoparticles in previous studies have shown promising anti-cancer activities, and also in Africa, fortunately, we have got medicinal plants which have been used for the treatment and management of prostate cancer, and combining the anti-cancer activities of zinc and copper nanoparticles with the African medicinal plants, we offer a new avenue for the development of new treatments against prostate cancer. And as you can see on the right, that's a zinc nanoparticle attached, being kept with phytoconstituents which are anti-cancerous. Hello, are we together? Okay, then our objective was to develop green synthesized zinc and copper nanoparticles which are kept with the medicinal plants, Bulbinella, Floribunda, and Asparagus africana. And we were supposed to evaluate their bioactivity and assessing their cytotoxicity and oxidative stress modulation. So bottom there, those are the plants, medicinal plants. On the left, that's a yellow cattail. That's B. floribunda, has been known for its activity against prostate cancer cells. And on the right, that's African asparagus. This plant has been used over the cells of prostate cancer also, but also it treats the symptoms which are associated with prostate cancer, like renal insufficiency as well as episodic pains. Then going to the methods, we started by plant extraction, and from that we carried out green synthesis. And in brief, green synthesis, this is just bioreduction of zinc and copper metals using the plant phytoconstituents, and that's where the term green synthesis is derived from. And from there we characterized the nanoparticles, and from there we also carried out cytotoxicity testing on somatic and as well as prostate cancer cells. And we were supposed to do a comparative studies using the existing therapies, docetaxel and enzalutamide. And finally, we evaluated the therapeutic potential. And turning to the results, we visualized this is ACM analysis, and we were looking at the shape of the nanoparticles. And upon phytochemical analysis, we found the abundance of phytoconstituents which are responsible for the anti-cancerous activities. And the examples are flavonoids, alkaloids, saponins, and so forth. And these were very abundant in this plant, supporting their use in the management of prostate cancer. And on bioactivity, we assessed the antioxidant activity of these plants, and we found the zinc and copper nanoparticles being very antioxidant, and this was supported by the abundance of phenolic compounds. And we also assessed the cell viability. Cell viability is just to assess their activity on causing apoptosis on prostate cancer cell lines. And we found the comparative apoptosis rate as well as the cell viability. They were comparative to the existing therapies. In this case, we used docetaxel and enzalutamide. And the picture, the micrograph on the bottom is showing the cancerous and the normal cells of the prostate gland. And in discussion to this, this is a cancer treatment advancement. Since zinc and copper nanoparticles, they inherently cause apoptosis, which enhances prostate cancer therapy with lower toxicity. And to this, we are adding these effects by using medicinal plants in Africa, B. floribunda and Agaricus africana, to enhance their efficacy against prostate cancer. And this is a targeted delivery caused by the shape of the nanoparticles. They were spherical and cuboidal, which can make them very targeted to prostate cancer cells. And this is an affordable solution to prostate cancer management. And all in all, this fosters collaborations and integrative health towards prostate cancer. And our future perspective, we are planning to carry out thorough clinical translation and validation so that we assess the long-term safety. And we also need to optimize drug formulation, and at this point I'm going to explain it in the next slide. And we have to expand the therapeutic applications because prostate cancer is also associated with immune suppression. So we have these plants can also boost the immune system, and we have to scale this up as well as doing more studies like AI-driven drug discovery, so that we isolate the key bioactive compounds that are active against prostate cancer. And that's our first breakthrough. We have developed a prostate nanogel. This is a topical application this is a topical nanogel which is smeared around the prostate area, and from there the nanoparticles they diffuse and get into the circulation and target the prostate cancer. And this one, we have started distributing it since August, and we have noted some testimonies. Our patients are saying there is a reduction in renal insufficiency, as well as reduction in pain episodes, as well as the reduction in prostate cancer progression. And this is a localized treatment, and it's eco-friendly, it's non-invasive, and it can be scaled up, and you get promising commercial potential. Then, in conclusion, this is a synergistic therapy, since we are combining the anti-cancerous activity of zinc and copper nanoparticles with the anti-cancer activity of our indigenous medicinal plants. And this offers a cost-effective alternative to prostate cancer management. And all in all, this combines modern science with indigenous knowledge for sustainable health care. And this has got a greater healthcare impact, since this offers affordable solutions which are scalable for prostate cancer management. And this can help patients, prostate cancer patients in Zimbabwe and beyond. And this also fosters collaboration between traditional healers, pharmaceutical scientists like me, and as well as the pharmacists. So these are my acknowledgement. At this point, I will be pleased to take some questions.
Thank you so much, Zena, for that wonderful presentation, which is looking at the novel ways and that breakthrough in prostate cancer. Let's give him a round of applause. Thank you so much. Any questions for him before he goes off? Any questions for our presenter? Okay. Once again, let's give him a round of applause. Thank you so much, Zena. Greetings to everyone.
Yes.
Zimbabwe. Thank you. So,
okay, thank you.
We just about item left on the agenda. Let's wish that we be patient. For a few minutes, we'll be able to go home and rest and prepare for the most hectic day, more welcome of the area of science going in and out. Yeah? So then we welcome our partners and exhibitors, take up the floor. I request to have someone from Brown Health. Someone from Brown Health. Kemmat. Anyone from Kemmat? Please come and take up the floor. Biohealth Africa. Biohealth Africa. Trunan. Anyone from Trunan? Anyone from Crown Health? Let's see if we see any. Kemmat? Anyone from this? Let's come very fast. We just use a few minutes and get out of this place. Biohealth Africa? Biohealth Africa, oh, I see someone there.
It's okay, but as well we have their leaders here. Their leaders there.
This.
That lady.
Anyone comes from Kemmat? You can tell us about the project itself.
They're like a team, but she's their coordinator.
As you wind up the day. Also, someone from Biohealth can come and tell us about the products they have. It would be great. If I see doors, more you're going to be making, you can see without this side. There is no music. Every time there is equal silence, come and give us a freestyle. Our dear exhibitors and partners, they were waiting for you. We're the ones who are standing between our departure. The first person to reach here, I'll give you the microphone and you talk to us. We always have 7 minutes each.
Or if not, we can have them come.
Yes.
Okay. That's me having the worst day ever. But then I saw them and
His business is going to be real business, so that's why as much as possible to come to play. So then we can start to play. All our
Tension is more of surgical, operating tables, both manual and electric. Then Thermo Fisher Scientific, for this particular event for the test and treat, Thermo Fisher provides us the cooling solutions, that's the freezers and the fridges. I'll be able to show you some of the equipment in the next slides, but just to highlight before we get there. For the point of care, how it looks like, some of us have already appointed ourselves with this or are familiar with this. It's a VivaCheck, easy to use, very accurate and reliable. It comes with, the machine comes with 3 packets of tests. Each packet has 50 test kits. So you buy 3 packets, you get a free machine at 105,000. Similarly, VivaCheck manufacturer is the same as used for VivaDR, but the same, they just try to give a different brand to the products. This is an HD meter, just like we've seen the glucometer. The story is more like the same. Standard, just like I mentioned, point of care, a BP and a stethoscope on that line. Not only do we deal with laboratory equipment or medical equipment in that line, we also do microbiology. Just like here in Victoria, we have some of the bottles of culture media, specifically biolab. Treating just like I mentioned, hospitals, laboratory, consumables in that line. This is more CDC machines, just like we have on the table right there. We pass around, some of you have already done so. Reliability or consumables more tends to be a scary kind of thing when it comes to offering USBC. At Kemat, that's something we all sorted with. We have a continuous flow of these consumables. This is how our chemistry fully automated appears to look like, just like the device. The outstanding feature in this is it measures all chemistry parameters. Its outstanding feature, just like you can all see, it has an embedded computer settlement. Unlike some other brands, which may necessitate you to have a separate computer set. So this you have in your laboratory, you have especially it's more to do with doing the space questions. This is your recommendation for you. Thermo Fisher Scientific, some of their productions look like these ones here, a freezer, maybe a fridge, specifically to make also a laboratory to assist with their chemistries. They not only do the cooling, but also do other equipment, like here is a centrifuge, 8 buckets. Tension, to react more surgical, some operating table, a manual one, but like I said, we also have an electric one, very reliable, premium steel, stainless steel. So it's just for one kind of products to offer. Now here is Sonoscape as a brand for the ultrasound machines. A1 and S11 Plus. This more of a globular kind of imagery. One of them is colored implant and the other one gives you entirely colored 3D imagery. More of emergency and support system. We have this here, the stretchers, and that line, so many, just to hit on a few. For your vital signs, we have this brand here, BioLite, which offers this basic parameters. They also have models to do the multi-parameter. Thank you very much. I can only request each one of you to reserve some time, someday or today or the other day, to pass by our premises, It's to do with you gaining confidence in us as we are well established. Also not to forget, we also have smear pockets for the cervix. It's to go out, of course, like down here, as the French say, you draw your finger to check. But then there is a kit we have, I'm not be able to put it here, but I have it on the desk and request those interested to come by to demonstrate to you. Thank you very much.
Thank you so much, very much. Let's give him another round of applause. Thank you for the presentation and also for sponsoring this conference. So please, if you get time by this, and also next time we need anything to restock your facility or your institution, please think of those suppliers. Where I come from, we have the same. Whoever gives this, this is what you give. At work or one. So, need to support them, support us. Thank you so much. We'll have more of this tomorrow. And also, we get different information lists. I think we look at the way very well. Something that was something itself. We've got thank you.
Thermo Fisher Scientific ultra-low temperature freezers. What's critical to understand is that no matter whether you purchase the standard performance unit or the top-of-the-line TSX units, you're never compromising on sample security. All units are designed for protection of samples. That is our #1 goal in the design of these units. When we look at our RDE or FDE or TDE series in the standard performance, these units are powered by H-Drive. So this refrigeration system is designed for quick recovery after door openings, good uniformity, low energy, low noise. As we move up to our TSX unit, this uses V-Drive. V-Drive incorporates additional benefits from the standpoint of greater uniformity, even lower energy usage, and some additional features that are built into the unit.